Hello, welcome again. Today we are going to solve some neuromuscular question. Certainly that includes some neurological high yield point as well. So let's talk about a 52 years old man presented to us with a 6-month history of progressive weakness. That is very important. The weakness that will involve the fine motor coordination in the right hand, then it involving the right arm and later all extremities. Okay, so the thing that we should remember in mind that sometimes in the motor neuron disease or other disorder, they will present like involving one limb, then simultaneously it will spread to other limb involvement as well. Okay, so on examination, he has dysarthria, reduced gag reflex. There is generalized motor weakness and atrophy, and the deep tendon reflexes are hyperactive in both upper and lower limb. That is very high yield. Okay, so that is, as you can see, there's a muscle atrophy and atrophy with hyperreflexia. Sometimes there is also ankle clonus, fasciculation is present. So here, as you can see clearly, the atrophy and fasciculation will be a feature of lower motor neuron. On the other hand, the deep tendon reflex exaggerated with ankle clonus is positive. These are the feature of lower motor neuron. So there is combination of both upper motor neuron and lower motor neuron. Okay, whenever we see a combination of upper motor neuron, lower motor neuron, we should think of amyotrophic lateral sclerosis. Okay, so it is one of the disorder of the motor neuron disease that is in that tends to get involved in both upper and lower motor neuron syndrome. Okay, the progressive muscular atrophy, on the other hand, is the isolated lower motor neuron syndrome. The primary lateral sclerosis is typically upper motor neuron syndrome. Okay, and the spinal muscular atrophy have a lot of variants. I'll come to this later. And the Kennedy's disease, it's a X-linked spinal muscular atrophy. It is a muscle disorder that will also involving some the diabetes. Also, there is some gynecomastia, testicular involvement. All of these facts will be present in this case. So in this case, the patient history and examination and evidence of upper motor neuron and lower motor neuron that will involve the amyotrophic lateral sclerosis. We should always remember the male is the male sufferer here. It tends to get the sporadic case will involve more in case of male. Okay, the hallmark of amyotrophic lateral sclerosis, there will be both upper motor neuron lesion and lower motor neuron lesion. The upper motor neuron lesion will be there is hyperreflexia, there will be clonus, and there will be positive Babinski sign. Or on the other hand, the lower motor neuron, there could be atrophy, fasciculation. Okay, so there will be the combination of upper and lower motor neuron disease that will be typical of amyotrophic lateral sclerosis, as I discussed earlier. Now, clinical feature, there's some other feature as well. Sometimes there could be split hand syndrome. Okay, what is split hand syndrome? There will be, wasting of the lateral hand. So the thinner and the first dorsal interosseous tends to get involved more with relative sparing of the medial hand. So the hypothinner muscle will be spared, but thinner will be wasted. So, in a hand, there is a typical both involvement feature. The hypothalamic is wasted with the sparing of the, the thinner will be wasted with the sparing of the hypothinner. That means the medial hand is, safe and lateral hand is wasted. So in the, that will be a split hand syndrome that will be typical of motor neuron disease. Now, approximately 1/3 of the cases, they have the bulbar syndrome, like, dysarthria, there could be dysphagia, there could be tongue fasciculation as well. So, whenever we get the, tongue involvement or the dysarthria, we should not think always of only of progressive bulbar palsy. It could be amyotrophic lateral sclerosis also. Sometimes a good number of cases of ALS, they will have involvement of the bulbar muscle onset. Okay, so in case of pseudobulbar palsy, sometimes there could be pathological laughter, crying without a corresponding changes in the mood, and sometimes excessive yawning occur in the ALS do not necessarily suggest an alternative diagnosis. There will be always some mood changes in case of pseudobulbar palsy. Okay, so minority syndrome, the most important cause here could be, respiratory failure, but that treatment is a bit improved nowadays, so there could be a lesser possibility, but still there is the important cause of death is respiratory failure. Sometimes, there could be some association of the frontotemporal dementia. In ALS, there could be some cognitive impairment. Whenever we get some cognitive impairment, that will be significant. We should think of the progressive involvement of frontotemporal dementia. So in case of ALS, there are some variants. First variant is split hand syndrome, we should remember. Second variant is frontotemporal dementia. Okay. Now, sometimes there could be association of bulbar onset ALS, as we can see. The patient involved presenting with frontotemporal dementia have clinical and electrodiagnostic feature of motor neuron disease. Okay, the feature that is combined of amyotrophic lateral sclerosis with frontotemporal dementia, they have the ubiquitin positive, tau positive, TDP positive, tau negative inclusion. So this is very important information. The patient with ALS with frontotemporal dementia, they might be having ubiquitin positive, TDP43 positive, tau negative inclusion. Tau is more positive in case of Alzheimer's disease. Okay. Okay. There's some other form as well. Sometimes, there could be a mutation in the TDP43 gene in the chromosome 9. There could be C9. The C9 ORF72 is another variety. Okay. So we should remember this fact also. So that is the thing we should remember. Okay. So sometimes, there are some nucleus. So there's some nucleus as well. That is the ONAF nucleus. ONAF nucleus is particularly spared in amyotrophic lateral sclerosis. This is the nucleus that is important for the sphincter control. Okay. So sphincter control is typically not a prominent problem. Sensory nerve involvement and dysautonomian feature is also very much uncommon in amyotrophic lateral sclerosis. Though in rare cases, there could be some involvement, but it is not that much common. Okay. So amyotrophic lateral sclerosis, it is progressive, first of all. Second important thing is that there could be fatal within 2 to 5 years of the onset. Okay. And the most important thing that approximately 20% is survive longer. And unfortunately, 20% survive is longer, more than 5 to 10 years of the systemic onset. Okay. So as I told earlier, we'll discuss about primary lateral sclerosis, progressive muscular dystrophy, the Kennedy's disease. Yes, Kennedy's disease also, spinal muscular, various types of spinal muscular atrophy as well. So in case of Kennedy's disease, as I told earlier, there will be family history. And second thing, there will be gynecomastia. It's very important. So which one of the following statement correct in regarding the question 1? So as you can understand, the diagnosis of amyotrophic lateral sclerosis, so we'll talk about it right now. So the dysphagia, dysarthria are rare as a presenting feature. They do not typically occur as the disease progresses. Absolutely false. Okay, because a lot of people having the bulbar onset, the amyotrophic lateral sclerosis. So dysarthria and dysphagia is quite common. Okay, particularly in the bulbar onset amyotrophic lateral sclerosis. Next is acute respiratory failure is a common initial presentation. It's not initial presentation. In the advanced case, it's an important cause of high risk of mortality is the respiratory failure. It's not acute case. It's actually the chronic involvement more importantly. Third important thing is that urinary incontinence and impotence occurs early. The issue is that in amyotrophic lateral sclerosis, the ONAF nucleus is particularly spared. Okay, so there will be less possibility of having any urinary complaint. Okay, so the cognitive dysfunction is present in many cases. It's absolutely true. I guess this will be the most correct option, because there could be some associations of the frontotemporal dementia. In that case, there will be atrophy of the frontal and temporal lobe, so they might be having ubiquitin and TDP43 positivity with tau negativity. So cognitive dysfunction, they could be present. So this is true, I guess. Now let's talk about the last symptom. Pseudo-bulbar effect. Pathological laughter or crying is not a feature of a disorder, and this should prompt evaluation of other causes. The most important thing is, as I told earlier, the pathological laughter or crying is a feature of the pseudo-bulbar palsy. That could be involvement. So it is also an important feature, particularly in amyotrophic lateral sclerosis. So same discussion possibly ongoing. So I go to the high facts once again for better understanding of all. The clinical feature is variable. The weakness focally. They will get involved one limb, then tends to get involved in the all other limbs as well. There could be split hand phenomenon. That is a very important feature. In that case, there will be wasting on atrophy of the lateral side and sparing the medial side. Okay, sometimes they're having the bulbar onset ALS, they're having, the particularly the bulbar onset dysarthria, dysphagia, also salluria, that could be a feature important. In pseudobulbar palsy, there will be some, pathological laughter, also crying, excessive yawning, that could be important feature as well. Only a minority patient of acute respiratory failure. The most in the advanced cases, there will be association with respiratory failure. Okay. So the cognitive impairment occurred in a significant amount of cases of amyotrophic lateral sclerosis. Okay, so cognitive impairment is very much common. And second thing is that, there could be association with frontotemporal dementia. Okay, frontotemporal dementia, they will having that atrophy of the frontal lobe and temporal lobe, also having ubiquitin positive, TTP positive, tau negative. That is very, very important, I guess. We should remember. On-off nucleus is spared, so particularly the sphincter dysfunction is not a prominent problem as well. And it's relentlessly progress. And after 2 to 5 years of the symptom onset, there will be a significant amount of fatality as well. Now, there is some drug as well for the treatment of motor neuron disease, particularly amyotrophic lateral sclerosis. The drugs that riluzole, that will expand the the survival benefit for up to 3 months. And in comparison to the riluzole, the other treatment is quite good in case of motor neuron disease. They will involve particularly you can give the patient non-invasive ventilations. They are very good, and they tends to improve the prognosis in more than riluzole. Now, the next question. A 16-year-old boy having progressive bilateral lower extremity numbness and weakness. So there is bilateral lower extremity numbness, also weakness, and difficulty in walking for a couple of months. Okay, his report worsening over the last 5 days. And this morning, when he wake up, he was unable to move his leg and felt numb from the tongue down. Okay, so there is some difficulty and numbness, and also difficulty in walking for last couple of months. Also, there is some worsening in last 5 days. In the morning, whenever you wake up, and he was unable to move his leg and feel the numbness in both trunk down. So on examination, there is significant weakness and spasticity, hyperreflexia. There is sensory level. MRI typically shows, and what will be the possibilities there? As we can see, this is not sudden onset. So in case of, if it is not sudden onset, we will rule out the ischemia. We can rule out the, it is on the background of some days or some moment. So you can also rule out the demyelitic possibility, the transverse myelitis, and that could be a lesser possibilities here. So in case of, as you can clearly see, there's some problem here. What are the problem? This is cervical 1, 2. Okay, this is cervical 3, cervical 4, cervical 5, cervical 6, cervical 7, thoracic 1, thoracic 2. Okay, so issues here. So I guess we can add always 1 with the thoracic level. So the vertebral level is T1. So the sensory level could be T2 most likely. So there is, as you can clearly see, the sensory level in the T2. And second thing is that there is some, swelling. As you can clearly see, there is some issues ongoing on here. Okay, so in the couple of background of 2 months, it could be a possibility of having any sol, right? So let's talk about the possibilities. First possibility is that it is a transverse myelitis, very much unlikely. Why? Because it's not acute. Cord infection, it's absolutely acute. It's another less possibility. Cord compression from metastatic tumor could be a possibility. Epidural hematoma could be another possibility. Meningioma with a spinal cord compression could be another possibility. Okay, so as you can clearly see, it is not actually, it's involving more in the meninges, I guess. So it's a defined lesion. Okay, this lesion is involving only the spinal cord. It's not bony involvement. So metastasis could be a lesser possibility. Okay, so I guess it's a more possibility of having any meningioma spinal cord compression. As you can see, there is an intradural extramedullary tumor. It's inside the dura mater, but it is the extramedullary tumor that will typically involve the meningioma. The tumor is typically located, as you can see, there is a lot of vertebra. This is the C3, 4, 5, 6, 7, C7, T1, T2. There is a lot of involvement. C7, T1 will be the most important, alongside some T2 involvement as well. So it is C7, T1 vertebral level. It's a dural Dural base, definitely. Meningioma, it's the most common intradural extramedullary tumor. We should always remember. It is the most commonest intradural extramedullary tumor. Okay, so that will be involving inside the dura mater, but outside the medulla. As you can see, it is compressing the the medullary structure. It is compressing the cord as well. Okay, so it's a non-glial neoplasm. It's actually benign, but the issue is that it can compress. Whenever it can compress, they might be having some troublesome symptoms as well. Patient do not have any transverse myelitis or cord infarct, so the presentation is not acute. It is actually, more or less involving a lot of time. So it's a subacute to chronic phase, right? So the MRI feature should be, there could be parenchymal cord-lesion, and it's not a. In that case, there will be cord-lesion. There should not be any extramedullary mass like this scenario. The spinal cord infarct, it is actually involving a very acute involvement. They will involving, according to the zone of artery, there could be anterospinal artery occlusion. There could be posterior spinal artery occlusion. In case of anterospinal artery occlusion, there will be, apart from the motor weakness, there will be involvement of spinothalamic tract. In case of posterior spinal artery occlusion, there could be involvement of dorsal column as well. So it will be entirely depend upon the patient's complaint as well. Okay, so acute transverse myelitis progresses over the hours for a few days or a few months. So very important. So it will involve few days to after a few months. Okay, so few days. The most important thing, the acute transverse myelitis will tend to progress within few days. The metastatic tumor will be a subacute presentation. There could be back pain, and it is more rapidly developing in compared to this scenario. Okay, so epidural hematoma is also occurs very rapidly. The patient will be having the spinal shock. Whenever a acute presentation like transverse myelitis or epidural hematoma that will be occurring suddenly, there could be associated spinal shock. So we'll get in the first place, we'll get some sensory level at that time. At that time also we should get all the charts are diminished in the first presentation. So the chart will be diminished in the first presentation with a sensory level that could be associated with spinal shock. But in this case, it's a chronic involvement, subacute to chronic involvement. In that case, the chart will not be diminished. So chart will be present and exaggerated and associated with sensory level. Okay. So whatever I want to tell you that whenever we got a spinal shock, the chart will be diminished. Acute condition will be having more association with a spinal shock as well. Now, there is some other option as well. So whenever we want to treat a patient with amyotrophic lateral sclerosis, something we should always remember. First of all, how will you progress the patient? How will you evaluate the patient? How will you assess the patient? We should check regular respiratory function. So how we can check the respiratory function? First of all, the nocturnal situation. We'll regularly check the nocturnal oximetry. So we should check about the pulsation and the saturation at the time of night. So the nocturnal oximetry is a very important thing. Second is the force vital capacity, the FVC. So the patient should be checking should have to check the supine FVC. Okay. Third important thing is that there could be maximum inspiratory pressure. These things should be assessed. So nocturnal oximetry, supine FVC, and supine maximum inspiratory pressure. Okay. And the patient will be having some, the trouble of involving the bulbar onset. So the evolution of swallowing function should be assessed as well. Why? Because to prevent the risk of aspiration pneumonia, there will be a good possibility of patient developing the aspiration pneumonia in the long run of having amyotrophic lateral sclerosis. So whether the patient will having some swallowing problem, that will guide us or dictate us for a possible management of PEG tube insertion or having any other hydration possibilities. Okay, so that is important. Third important thing is that there could be refractory sialorrhea. So a lot of patients came to us with having a salivation, or yes, we have been having a lot of salivation problem. So patient will come to us with sialorrhea. So whenever we get a patient with sialorrhea, we should treat the patient with parotid or submandibular toxin as well. Okay, and the patient is having some mood problem as well. It's a very important. The patient is having some pseudo bulbar effect, what we called, as I discussed earlier. Sorry, extremely sorry. for the interruption. Patient will come to us with having some pseudobulbar effect. At that time, the best treatment will be dextromethorphan plus quinine combination. So dextromethorphan quinine will be the best treatment. So this thing we should remember. The first important thing, what will be incorrect? The parotid and submandibular botulinum toxin is absolutely effective. It's an absolutely wrong answer. Second thing, it's evident to suggest the management of ALS in the multidisciplinary clinic is beneficial. Of course, it's beneficial. We need to look a lot of aspects in order to treat a proper patient. Okay, patient properly. We should have to having a multidisciplinary approach as well. Riluzole is a inhibitor of glutamate release. Okay. Of course, it is an inhibitor of glutamate release. So the tendency of releasing glutamate. So the glutamate excitation is associated with more the nerve damage, muscle damage as well. Okay. So however, the riluzole will inhibit the glutamate release. So the nerve supplying the muscle having a protected. So I guess their disease progression a bit slowed. So that's why riluzole is having the survival benefit or prognostic benefit for about 3 months. Okay, but it's a so much less amount of time in compared to the cost of the riluzole. So frequent evaluation of swallowing function is very important because the patient having increased risk of aspiration, as I told earlier, and periodic assessment of lung function, they are indicated. So these are the things we should remember. So guideline has been issued by American Academy of Neurology to guide the management of patient with amyotrophic lateral sclerosis. The majority of the patient experience hypoventilation. Orthopnea is a very good and very unfortunate problem patient. Okay, so in case of nocturnal oximetry, the supine force vital capacity, the supine maximum inspiratory pressure, they should be periodically assessed. Okay, second thing, the swallowing should be periodically assessed. And whenever we are needing any PEG tube or any other measures, they should be implemented ASAP. Third important thing is that the patient having riluzole, it's an inhibitor of glutamate release. As I told earlier, it prolonging the survival for about 3 months as well. The issue is that there's some things we should check like blood count or liver enzyme. Okay, and as I told earlier, the dextromethorphan quinidine combination is very important for any pseudobulbar effect. Sorry for the answer trouble. Okay, so next important question, a patient with chronic progressive myelopathy present with evaluation. Okay, we need to evaluate the patient. I am suspecting it's a B12 deficiency. So what will be the incorrect option here? So I will come to it about, I will come to last option. The most important cause of B12 deficiency is malabsorption. Okay, that is, I guess, a possibility is here, a significant cause of malabsorption. Vitamin B12 in serum is the only laboratory test need to be followed when treated this patient. Sometimes, there could be some option. They, sticks and they will, drive crazy that, yes, it is the wrong. It's something like that. So never ever think about that. It's the only test. It's only done. It's the only possibility. It should not occur. So there could be a possibilities there. So the vitamin B12 with the serum is not only diagnostic test, of course. It can cause white matter vaporization, white matter demyelination. That could be a possibility. Elevated gastrin level in anti-intrinsic factor antibody, anti-parietal cell antibody associated with B12 deficiency, particularly having the pernicious anemia. Whenever you got a patient of pernicious anemia, there could be anti-parietal cell antibody, anti-intrinsic cell antibody. There should not be any hydrochloric acid. There should not be any intrinsic factor of Castle. Whenever we don't get any intrinsic factor of Castle, there should not be any B12 absorption as well. So it's absolutely true. The vitamin B12 level may be within normal limit despite clinical manifestation of deficiency. It is also absolutely true. Sometimes we got a lot of patient having, subacute combined degeneration, having an absolutely normal B12 level. So B12 level is not a predictor sometimes for the absolute damage of the subacute combined degeneration of the spinal cord. Okay, so what B12 does? B12 in normal cases, it will convert it into it is converted into homocysteine to something called methionine. Okay, in our body, there is a product that is called the homocysteine. What B12 does, that it converted homocysteine to methionine. Now, what methionine does, that it is very important to form the myelin basic protein. And what is the myelin basic protein? It is important for the myelination, right? So whenever we are getting a B12 absent, we cannot form the methionine, so it won't be there. We will not able to form the myelin basic protein. So there will be demyelination of the certain tracks, okay? And the important thing is that homocysteine level will be elevated, okay, as there will be no methionine. Okay, so methionine is a very important thing. They can form the through some enzyme, possibly it is S-adenosyl methionine, to convert into myelin basic protein. Whenever we got a deficiency of B12, there will be less myelin basic protein as there is no methionine, okay, and there could be some association with white matter vacuolization. So white matter vacuolization is very much important. On the other hand, sometimes in B12 deficiency, there could be accumulation of the methionine, and another function of the vitamin B12 that it convert the methyl malanoic acid to the succinyl CoA. So as the B12 deficiency, there will be elevation of methyl malanoic acid. So whenever we got a patient of B12 deficiency, we are getting some, increased amount of homocysteine, also increased amount of the methyl malanoic acid. So we should remember this fact as well. So let's check the answer. Okay, I guess it's already checked. The serum methyl malanoic and homocysteine level should be obtained when you got a patient with B12 deficiency. Okay, so sometimes in B12 deficiency, the levels is absolutely normal, but we should check the methyl malanoic and homocysteine level as well. So sometimes the important manifestation is subacute combined degeneration of spinal cord. There will be peripheral neuropathy, there will be optic neuropathy, and there will be cognitive impairment also. B12 is an important cofactor for the enzyme methionine synthesis that convert the homocysteine to methionine, then which is then adenylated to sorry, S-adenosyl methionine. S-adenosyl methionine is required for the myelin basic protein. Okay, whenever we got reduced myelin basic protein formation, there will be some problem. Okay, so the myelination will not be there, and there will be associated white matter vacuolization. Okay, and whenever we got a low vitamin B12, low methionine level, secondary to B12 deficiency, they impair the DNA synthesis as well. So another important pathway that vitamin B12 also convert the methyl malanoic CoA to succinyl CoA as there is B12 deficiency. So there will be increased accumulation of methyl malanoic acid, particularly methyl malanoate. So there will be some problem ongoing in myelin synthesis also. So in a nutshell, there will be having spinal cord troubles. Okay, so there will be involving of the dorsal column, involving of the corticospinal tract. So corticospinal tract associated with upper motor neuron, dorsal column causes neuropathy. The combination of the upper motor neuron and neuropathy having a subacute combined degeneration of the spinal cord. Okay, why combined? There is a dorsal column involvement with the corticospinal tract involvement. Now the etiology. Okay, so etiology is very important here. The most common etiology is malabsorption, particularly, as I told earlier, there is some association with pernicious anemia as well. Okay, sometimes, there could be terminal ileal disease, that could be another possibility. Pancreatic enzyme, that is another possibility. Sometimes chronic pancreatitis with malabsorption can have the vitamin B12 deficiency. Okay, so sometimes we can get the B12 level normal. Okay, but we should check in order to confirm the homocysteine level and methyl malanoic acid level. Also as well as copper level also, because sometimes copper deficiency can present in a similar fashion or similar manner like the B12 deficiency. So a 52 years old woman come from Ohio who has not traveled outside the state in her entire life. Okay, so she likes to stay in the home as well. Okay, so she is having the gait difficulty. Extremely sorry, I'm going to omit it also. The issue is that we're not solving the question, we are solving the question to get enriched about the knowledge about various types of disease, right? Okay. Yes, of course. Thank you. Now, a 52 years old woman from Ohio who has not traveled outside the state in her entire life, having gait difficulty for 3 years duration. So 3 years has been occurred. Okay, there is no family history of similar problem. On examination, there is significant lower extremity spasticity with seesaw gait, that is spastic gait. There is bilateral ankle pronus. The Babinski sign is present bilaterally. The deep tendon reflex are pathologically bridged throughout, especially the knees and the ankles. There are no fasciculation. The sensor is absolutely normal. The MRI is normal. What is the most possible diagnosis? Okay, so there is no hereditary possibility, no family history, hereditary gone. There is no other travel. So tropical area, no tropical air traveling. So tropical is also less possibility. We will omit these two possibilities. Okay, cervical spondylosis, there is no neck pain. Okay, moreover, the all MRI of brain and spine is absolutely normal. So we can omit that also. So possibilities: amyotrophic lateral sclerosis and primary lateral sclerosis. One thing we should remember: if the history involves the 3 years, so there is 3 years involvement, it is unlikely to be present amyotrophic lateral sclerosis, as there is upper motor, there is no lower motor. Okay, it's unlikely to, patient will develop lower motor feature alongside upper motor to convert a primary lateral sclerosis to amyotrophic lateral sclerosis. So the 3 years, we should remember 3 years. So there is 3 years. There should not be any further, scenario in this scenario. There is upper motor. After 3 years, it will be upper motor. Okay, so there will be upper motor involvement. It is primary lateral sclerosis. Same thing goes to progressive muscular atrophy also. Okay, so primary lateral sclerosis characterized by presence of upper motor neuron sign at least 3 years from the symptom onset without the evidence of lower motor dysfunction. The PLS is considered to be a spectrum of amyotrophic lateral sclerosis, though it is controversial as it is whether or not. It's a separate entity. First important thing is typically present in the 6th decade. So there will be progressive spastic tetraparesis. There will be cranial nerve involvement as well. Rarely there is bulbar onset. Bulbar onset more frequent in amyotrophic lateral sclerosis or progressive bulbar palsy. Progressive bulbar palsy is always having the worst prognosis. Okay, spasticity rather than muscle weakness and atrophy is the prominent feature. Yes, you're right. So it typically progresses slowly over years. Autonomic involvement doesn't typically occurs. Autopsy in patient with primary lateral sclerosis has shown a significant loss of layer 5 of the cortex. Okay, what is the layer 5? It's a dead cell layer. Okay, so whenever you did the MRI, sometimes we can get the layer 5 cortical atrophy, but it's very much unlikely. We'll confirm it by autopsy. Okay, so there is a layer 5 atrophy with corticospinal tract degeneration. The majority of ALS who present with predominantly upper motor neuron sign and symptoms eventually develop to lower motor neuron involvement by 3 to 4 years. Okay, so the majority, that is very important, the majority of amyotrophic lateral sclerosis who present with predominant upper motor neuron signs would eventually should have any feature at least 3 years after. Okay, so the differential diagnosis of primary lateral sclerosis is broad. The patient will we need to do a lot of workup. We need to check about cervical myopathy. We need to check the sensory abnormalities. We'll need to check the bowel and bladder symptoms as well. Okay, sometimes bowel bladder symptoms patient can present like this. Okay, so there could be having a differential of cervical myopathy, the patient having sensory sign with bowel bladder involvement. Okay, so another possibility in primary multiple sclerosis. But issue is that there is no MRI findings, there is no sensory. The CSF findings should be there in that case. Tropical spastic paraparesis is due to human T-cell lipotrophic virus that is typically involving the equatorial region, South Africa and Caribbean, part of Asia, and also the Central and South America. So there's a less possibility here of human T-cell lymphotrophic virus involvement. Patient with hereditary spastic paraparesis is often but not always have a family history. So issue is that we should count her family history. This is not that much common possibilities there, but we should count on family history. There is no family history possible present here, so there's a lesser possibility. Another important thing is stiff person syndrome. that will be association with, glutamate acid decarboxylase antibody. This is a GAD antibody which should be assessed in a patient with presentation. There is some other possibility. They can involve the quadriparesis. They particularly involve the white matter tract of the brain. So what are those factors? Those are the factors that involving the leukodystrophy. There could be adrenomyeloneuropathy. There could be hexosaminase deficiency. They can having the leukodystrophy. They can having the paraneoplastic process as well. Okay, so the treatment of primary lateral sclerosis is particularly symptomatic. Okay, the most important thing is that we need to control the spasticity. So baclofen, tizanidine, that could be important option here. Now, sorry for the answer again. A 52 years old man, intravenous drug abuser, already developing HIV, CD4 of only 120, non-compliant with antiretroviral. So there is a lot of issues. Okay, so develops progressive neurological symptom over the several months. So whenever you got a neurological symptom in HIV patient, we should think of whether it could be toxoplasmosis or primary CNS lymphoma, or progressive multifocal leukoencephalopathy caused by JC virus, okay, or any other neurocognitive disorder and other condition as well. So we're getting CD4 of 120, progressive neurological symptom that will involve the ataxia, spastic paraparesis, and sensory loss. So there is myelopathy. This is not central nervous system involvement. Okay, so after examining, you are all suspected him to have myelopathy. Which one of the possibilities of HIV associated myelopathy? Okay, sometimes HIV itself can cause dementia. HIV can cause aseptic meningitis. HIV can cause myelopathy as well. Okay, so certain things we should remember in a patient with HIV associated myelopathy. First of all, it is a important vascular myelopathy. We should remember the patient will having a complaint of lateral and dorsal column involvement, particularly just like a B12 deficiency. So lateral column having the corticospinal tract involvement, so spastic paraparesis will be there. There is a dorsal column involvement will be there. So that's why the patient is having, ataxia. That could be sensory ataxia as well. Okay, so there could be some microvascular changes. Okay, it is another important, rightly called the vascular myelopathy. Another important thing we should remember, it will spare the upper limb, not associated with back pain. So these are the things we should remember whenever we want to think about the HIV myelopathy. So let's talk about the issues. First important thing, we are searching for the correct option. So human T-cell lymphotropic virus is a common etiology for this type of myelopathy. Yes, it is in case of tropical spastic paraparesis, the human T-cell lymphotropic virus is the issue here, but it is actually not involving the sensory in that common. Okay, so sensory involvement particularly is we need to think about other causes. And the pathological analysis of a spinal cord shows axonal degeneration. So there could be vascular myelopathy. Okay, so in that case, particularly there are some vascular changes there. The pathological analysis of the spinal cord show lateral and posterior column demyelination with microvascular changes. This is actually the right answer. B12 is not that much common. This scenario is typical to B12 also, but it is not common in HIV-related myelopathy. It is a coexistent condition. We can explain all of this by HIV itself. Copper deficiency important feature is not that much common, so I guess it is more important. Pathological analysis of the spinal cord shows a lateral and posterior column demyelination with microvascular changes. The patient having HIV is immunocompromised, as evidenced by CD4 cell count, having myelopathy. So we should remember of certain facts as well. Certain important infectious agent is a potential cause of myelopathy. They will involving the syphilis. There could be herpes zoster as well. There could be human T-cell lymphotrophic virus. Okay, so we should remember about the herpes zoster virus. There could be human T-cell lymphotrophic virus. There could be mycobacterium. Okay, there could be fungus as well. But the issue is that the most common spinal cord involvement in HIV, particularly HIV itself, okay, it's a vascular myelopathy. They will involve the lateral posterior column demyelination, having the microvascular changes with axonal preservation. They will not involve the axon, okay? So it is microvascular changes that we are dealing with. HIV-related vascular myelopathy patients with AIDS, affected patient having a progressive grade difficulty, spastic weakness, impaired dorsal column, there should not be any back pain, upper extremity will be spared. Okay, human T-cell lymphotropic virus, it is a spinal cord involvement. They can be present in HIV, but it is not causing the vascular myelopathy, and it is typically causes spastic paraparesis. Okay, spastic paraparesis will be most important factor, and the sensory involvement is not that much common. Whenever it's common, it will be absolutely painful, and the patient will be having some bladder dysfunction as well. Now, next question. Oh, thank God, there is no answer given. A 30-year-old man present with evaluation of progressive lower extremity spasticity. So there is progressive lower extremity spasticity, which worsened over the last 5 years. So young onset spasticity, 5 years. There is spasticity of the lower extremities, no involvement of lower motor neuron findings. So there is no evidence of lower motor neuron findings. So it's absolutely upper motor, no other neurological findings. He says that his father having similar types of problem, brother is starting to develop similar types of problem, workup negative, MRI of brain and cervicothoracic spine is unremarkable, B12, copper, CSF, we have checked, it's absolutely normal, no HIV, no human T-cell lymphotropic virus of tropical spastic paraparesis, even non-reactive VDRL as well. There is family history. So we should having the diagnosis in our mind, I guess. So it is hereditary spastic paraparesis. It's not tropical. So based on the family history and certain amount of history with wonderful presentation for unfortunate for the patient, for us it's wonderful, in order to diagnose. The patient will be having progressive worsening spasticity. The most important thing, there will be progressive worsening spasticity. That could be autosomal dominant, that could be autosomal recessive, that could be X-linked, that could be sporadic. So all of the findings could be there. Particularly, you should remember that the patient will come to us with 2nd to 4th decade of life. That is very important. Clinically, it has been defined into pure or complicated form. In case of pure form, there will be lower extremity spasticity. Sensory will be absolutely all right. Okay. In case of complicated form, there is other issues as well. What are those other issues? There could be optic neuropathy, there could be deafness, there could be peripheral neuropathy, ataxia, there could be dementia, there could be mental retardation. So a lot of problem will be there. Okay. So whenever we have to think about the hereditary spastic paraparesis, we should think about the pure form rather than the complicated form as well, because complicated form can occur in a lot of conditions. Okay. So whenever we want to think about the gene, it is hereditary spastic paraparesis. So the gene will be H, S, and P. That will involving the chromosome 2. Whenever the chromosome 2 will be involving a spas gene. So the spas gene encode for the protein is spastin. Okay, so the issues here, the spastin protein can have these sorts of problem. There's some other protein as well. So atlastin, that will be paraplegia. There's some other protein as well. Okay, so the issues that we should take, we should treat the patient symptomatically, concern the patient about the disability as well. That this is not monomelic amyotrophy or hemorrhagic disease. In that case, it will involve in the upper extremity. Okay, that will lower motor neuron findings. Patient will develop this feature, and after a certain period of time, the weakness stops. So it's a pretty peculiar condition. Will come to this later. And progressive muscular atrophy manifests as lower motor neuron. This is not a feature here, certainly. The next question. As you can see, a 78-year-old man having history of diabetes, also hypertension, having septic shock with a low pressure. Okay, so he admitted to the intensive care unit where the antibiotic and pressor started. Why pressor started? The patient probably having antiseptic shock. And over the few days, he improves. However, he cannot move his leg. He has a sensory level in the T6. The MRI shows a spinal cord T2 hyperintensity. Okay, so there's a lot of problem here. As we can clearly see, there is shock. Whenever we get a shock, and after that we develop a weakness, that will, tends to get more involved in the watershed territory. Okay, so as the patient is having a particular involvement of watershed, I guess most likely to involve in a watershed infarct. Okay, there is certain part of the spinal cord, like the mid thoracic region, that will involve the T4 to T8, as I can write here, T4 to T8. So the T4 to T8, it's an upper mid thoracic level. Okay, whenever we are dealing with the mid thoracic level, okay, that is the watershed infarct, because in zone above there is a particular circulation, in the zone below there is a particular circulation, and this zone will be having this blood supply from the combination of the leftover of the both circulation. So whenever we got a features of shock, the upper zone is getting blood, the lower zone is getting blood, the mid zone, that will depend on about the both upper and lower zone. They are more likely, beggars from above and lower. So they will devoid of blood. So the patient may be having any watershed infarct. Okay, so I guess it's the most likely watershed infarct could be a possibility. Yes, the patient is having a watershed infarct of the spinal cord, which can be occurred due to prolonged hypotension. The area of the spinal cord that are more vulnerable, that is the upper mid thoracic level, particularly T4 to T8, T4 to T8, as they get the blood supply from the vertebral column or the aortic circulation. So upper zone getting blood from the vertebral circulation, the lower zone is getting blood from the aortic circulation. So there could be a possibility of watershed infarct. Another important thing that we got the name about the artery of Adam Quick. This is the longest and very large radicular artery. They will involving from T8 to L3. They will give the blood to lower thoracic and upper lumbar region. So you should remember T8, L3, Adam Quick syndrome, Adam Quick artery. Okay. Okay. In case of epidural abscess and hematoma, there will be epidural collection. The patient wasn't having any epidural collection as well. Now the next question. The patient is having extremity weakness of 3 years duration. So another important thing, possibly we are thinking about another motor neuron disease, right? The patient begins weakness about the finger flexor and extensor. Also, there is some similar weakness involving the left hand as well. Over the prior year, the weakness has progressed. She could not abduct her arms beyond 30 degrees or fully flex or extend her forearms as well. The finger examination reveals significant atrophy of the proximal upper extremity muscle. There is fasciculation. So all are lower motor, right? There will be biceps fasciculation, deltoid fasciculation, diminished tone, diminished power as well. There is no clonus, absent Babinski, DTR could not be elicited in the upper extremity, 1+ in lower extremity, a wide spared motor dysfunction in the EMG. So that is typical pure lower motor after 3 years. So diagnosis is most likely it is progressive muscular atrophy. Okay, post-polio, it won't involving this sorts of symmetrical involvement. Spinal muscular atrophy could be a possibility, but we should think about the common condition first. Inclusion body myositis patient will involve the finger flexors with quadriceps. So there is no typical finger flexor with quadriceps involvement, particularly after 50 years of age. Okay, so progressive muscular atrophy is considered among the spectrum of ALS. This is controversial. This is a motor neuron disease affecting the lower motor neuron, distinguishing from amyotrophic lateral sclerosis, which is involving the upper and lower motor neuron. Okay, so it often presents an asymmetrical distal weakness, later involving the proximal region as well. Okay, so there could be atrophy, fasciculation, hyporeflexia, wasting. That is very important. Progressive muscular atrophy begins at any age, earlier age, compared to amyotrophic lateral sclerosis. Cervical often longer in this condition. Okay, so this is the condition having an excellent prognosis in compared to other condition. Okay, so bulbar respiratory muscle, they occur very late. Okay, lab investigation shows a moderately elevated creatine kinase level, EMG showing the features of motor neuron disease as well. In case of amyotrophic lateral sclerosis, as I told earlier, there could be lower motor neuron, there could be upper motor neuron, both presentation could be there. So we should make a diagnosis of PMA, progressive muscular atrophy, the patient having no feature of upper motor in 3 years after. So they may have, we may consider that to be a PMA. The polio will involve in the antrohorn cell, so the patient will having a lower motor neuron type of weakness as well. So those who survive, the patient will be having a post-polio syndrome. That could be progressive fatigue, weakness in the muscle as well. Okay, so unlike the progressive muscular atrophy, which progresses for a period of 3 to 5 years as well. Adult onset spinal muscular atrophy, they will tends to get more involved in the proximal muscle as well. Okay, and as I told earlier, the inclusion body myositis, it is involving the finger flexor with knee extensor. Only 2, 3. The finger flexor, knee extensor. We should think about inclusion body myositis, particularly the age will be more than 50. So let's talk about the blood supply of the spinal cord after omitting the answer, right? Yes. And that regarding the vascular supply of spinal cord, which one of the following is correct? So we should remember that in case of a spinal cord, there is 2 artery, anterospinal artery and posterior spinal artery. Always remember, anterospinal artery will be the one supplying the 2/3, posterior spinal artery will be the 2 supplying the posterior third. Okay, so anterior 1, posterior 2, A1, P2, A1, P2. Always remember A1, P2. Okay, now, so there will be 1 posterior spinal artery. Incorrect, yes. There will be 1 posterior spinal artery. This is absolutely wrong. There will be 2 paired posterior spinal artery. Okay, so there are 2 paired posterior spinal artery. They supply the spinal cord, forming a arterial network. Okay, anterospinal artery supplying the anterior 2/3 spinal cord, originated from the vertebral artery. Posterior spinal artery supplies the 2 paired posterior spinal artery, supply the posterior 1/3 of the spinal cord, originated from vertebral artery as well. So the anterospinal and posterior spinal both came from the vertebral artery. We should always remember as well. There could be sometimes, some segmental artery, some radicular artery. The largest radicular artery is artery of Adam-Wick, supplying the T8 to L3. We should remember the fact as well. T8 to L3. It's very important. The cervical and upper thoracic region receive multiple collateral from the vertebral artery. Similarly, the conus medullaris and cauda equina receive supply from the multiple radicular artery. So upper thoracic, cervical, conus medullary, cauda, they are getting a lot of radicular artery. The watershed region is T4 to T8. They can having a patient, whenever we get a watershed infection, this zone is very much vulnerable. Epidural venous system, we should remember it's a valveless system, and it extends from the pelvic region to the intracranial venous system. So whenever we're getting a tumor originating in the CNS or column, they will come from the pelvic region as well. Now, a 69 years old man having hypertension, hyperlipidemia, diabetes, coronary artery disease, peripheral vascular disease undergoes the endovascular intervention for a thoracoabdominal aneurysm. After the procedure, he has a new neurological finding attributed to anterior spinal artery infarct. On examination, what will be you expected to find? What will you get in that case, right? Now, there will be whether there will be paraplegia involving the sensation of pain and temperature. It's an anterospinal artery, right? With preserved sensation of the vibration and proprioception. Okay, that could be a possibility. Paraplegia, bilateral loss of sensation of the sense of vibration and proprioception. It's anterospinal artery. So the B will be absolutely wrong. Okay. Number 3, the loss of sensation of the vibration and proprioception bilaterally. Not that much, not buying it. 4, the loss of sensation to pain temperature bilaterally, preserve sensation to okay. Another thing is that weakness in one side, that could be less possibility. So I guess it's the A, the paraplegia with bilateral loss of sensation to pain temperature and with preserved sensation to the vibration and proprioception. As there will be anterospinal artery occlusion, the involvement will be the corticospinal tract, causing paraplegia, and they will be involving the spinothalamic tract, causing the pain and temperature loss with sparing of the dorsal column. So proprioception, joint position, sense of vibration will be spared. That will be the best answer in this case. Okay, that will be the best answer in this case. Now, next question. The spinal cord is an ascending and descending pathway attributed to white matter function. The corticospinal tract originates from the primary motor cortex. 85% fiber decussate at the pyramid. They cross over. Okay, they become the lateral spinothalamic tract. Okay, 15% fiber is the antospinothalamic tract. The dorsal column from fasciculus gracilis and cuneatus. These are the features as I told earlier. Okay, I guess we got it. The next question. A 70 years old man complains of back pain, lower extremity weakness, and a sensory deficit of all modalities below the mid-abdominal region for the last 3 days. Okay, since onset, his neurological manifestation has been progressed rapidly, that he's becoming paraplegic on the day of evaluation. The MRI as shown here. So there's back pain, lower extremity weakness, sensory deficit with a sensory level. So there's myelopathy. So as you can see, what is the issues there? So I guess, as you can see, this is the thecal sac. This is the cord. There is some problem here. Okay, there is some problem here. So these are the problems. So as I can see, it is approximately 3 days. Okay, there's some signal change, I think there is ongoing. No vertebral involvement, I guess. So there's some signal change. So most important factor. The most important thing is that the back pain, there is some extremity weakness, there is some sensory deficit, and since the onset, the neurological feature progressed rapidly, becoming paraplegic with MRI features. So let's see the option here. A episode of hypotension, recent aortic manipulation, atherosclerosis, dural AV fistula, warfarin for atrial fibrillation. Okay, so I guess there is back pain. The most important thing is that there is, I guess, back pain. So back pain with muscle weakness, back pain with spinal cord involvement in a period of, subacute or more than 3 days, I guess, 3 days. So I guess it is less possibility to having any infarct here. So the possibility will be atherosclerosis, okay, less possibility. Aortic manipulation, okay, I'm not thinking about that as well. Okay, there's recent hypotension, there is no watershed, in fact, I guess. So it could be back pain. Whenever we got a back pain in a spinal case, we should think about some atypical causes. Okay, sometimes the epidural hematoma. The epidural hematoma can having any back pain, particularly. Okay, and whenever we got a dural AV fistula, I guess you should think about slowly progressive myelopathy. It's not that much common. The fistula will not be present within the period of 3 to 4 days. So I guess it is more likely a epidural. I guess a hematoma could be there. That could be a possibility here. Okay, a hematoma could be there. So as you can see, what are the possibility can cause hematoma? Aortic manipulation and warfarin for atrial fibrillation. So there could be a very good possibility of having any warfarin for atrial fibrillation. Okay, so this is the epidural collection, more consistent with epidural hematoma. Okay, and the most common feature is back pain. There is myelopathic syndrome associated with back pain. Common association, you should think about the epidural hematoma. So what are the risk factors of epidural hematoma? There could be anticoagulation, there could be thrombocytopenia, there could be any vascular malformation. They can have association. Dural AV fistula, it's a vascular malformation, very good, but the issue is that it's insidious, it's slowly progressive. It will not occur in a within a period of 2 to 3 days, right? This manifestation caused by increased venous congestion and mass effect. They may lead to venous infarct. Okay, so acute hemorrhage can occur. Dural atriovenous fistula may rarely produce the epidural hematoma as well. So atherosclerosis, aortic dissection, aortic manipulation, they can cause ischemic infarct, but very unlikely to develop in such a small period of time. Prolonged hypotension may be associated with watershed infarct as well, as I told earlier. Okay, we got solved a question. So this is typical. We should think about a hematoma. Now, the next question. We have discussed about ALS earlier, so it will be easy for us to solve the question. So glutamate, which one of incorrect? Glutamate mediated excitotoxicity has been postulated as a cause. It certainly has been postulated as a cause as we are treating the patient with riluzole. Riluzole inhibits the glutamate. Okay, so glutamate can cause damage. So glutamate damage. Okay, the mutation of superoxide dismutase. That could be a possibility of ALS. Okay, sometimes we got a superoxide dismutase mutation. We can get in a 20% case of ALS having any SOD mutation. SOD mutation can have 20% of the ALS. Okay, no environmental exposure has been definitely, of course, there is no environmental exposure definitely linked with the amyotrophic lateral sclerosis. Another thing is that amyotrophic lateral sclerosis can have a lot of variant. There could be FTD variant. Sometimes the ALS can be associated with Parkinson's as well. Whenever the ALS is associated with Parkinson, we should think about whether it is a Western Pacific island of Guam. Okay. In that condition, in the condition of Guam, may be associated with ALS with Parkinsonism. ALS with Parkinsonism. Okay. So in case of ALS, we can think about Parkinsonism in case of Guam. Okay. We should think about Guam as well. Most of the familial majority is absolutely wrong. As we can see, approximately most of the case, like more than approximately 80%, they are sporadic. Okay. So the majority of ALS is absolutely sporadic. The familial ALS are, autosomal dominant, as I discussed earlier. Okay, and X-linked inheritance is quite rare in case of amyotrophic lateral sclerosis. The exact cause of the ALS is unknown. Various hypotheses, various environmental, various positive factors has been described, but there is no significant associations has been established. Okay, so majority of amyotrophic lateral sclerosis, the cases are sporadic. 10% are familial. The several genes has been implicated, particularly the mutation in SOD chromosome 21. They are approximately having the 20% cases of ALS. Okay, SOD 21, 20%. Another thing is that there could be some familial ALS also. The SOD protein is having some damage in the motor neuron, particularly due to having a toxic gain of function. Okay, so a rare form ALS associated with Parkinson, with frontotemporal dementia in a Western Pacific area of Guam. Okay, that is the Western Pacific island of Guam. We should remember this fact as well. Okay, so we will solve the next question. A 69 years old man, 6 months history of progressive lower extremity weakness. MRI has been shown in picture. Okay, let's see the MRI. Regarding the patient's condition, which one of the following is correct? Okay, as you can clearly see, there is, this is, sorry, wrong window, I guess. Okay, so we'll solve this. As you can see, this is cervical 1, 2, 3, 4, 5. So there is a lot of cord compression in this level, in this level, in this level, in this level. So there is a lot of cord compression. There is cervical myelopathy ongoing. So I guess it is a lower extremity weakness is due to cervical myelopathy. So on examination, also what will be the following? Which one of the following is correct? First of all, the examination, there will be evidence of atrophic fasciculation, lower extremity. Absolutely wrong, because there is compression here. We'll get atrophic fasciculation in this level, in this level, in this level, might be okay, in this level to some extent, but in this condition we will not get any atrophic fasciculation. Okay, there could be evidence of a spinal cord, a spinal shock. Whenever we got a acute onset condition will be having a spinal shock. Chronic condition will not be having a spinal cord spinal shock. Okay, so there's a 6 months history. The spinal shock will be unlikely. Steroid are indicated, not buying it. the radiation therapy should be started. Okay, on examination there is spasticity of lower limb, hyperreflexia, upgoing toes. So E will be the most important answer. Okay, so there will be history of cervical spondylotic myelopathy having spinal cord compression in the multiple level, slowly developing over months. The condition most common cause of spinal cord compression in the elderly. Spondylosis is a degeneration of the spinal column where there is formation of osteophyte, which eventually leads to compression of the cervical cord and nerve roots as well. So along this, there is a significant disc herniation. There could be ligamentum flavum hypertrophy. They may lead to narrowing of the spinal canal, and they can having these sorts of problem as well. So neurological symptom in this condition develop insidiously, unlike the acute cord compression. Okay, so acute cord compression may be having the spinal shock, so there could be a lot of duration. The patient will be having flaccidity, hyperreflexia, but there could be the sensory loss that will trigger us to think about the cord involvement as well, alongside of the sphincter dysfunction. The patient having cervical spondylotic myelopathy will gradually develop neck stiffness and pain, the weakness below the level of the compression, unsteady gait. Examination shows the findings of upper motor neuron sign below the level of the compression with spastic paraparesis, hyperreflexia, and upgoing toes as well. The upper extremities may have the weakness of lower motor neuron sign, reflexia, and atrophy. Okay, the patient having some sensory sign, like particularly whenever he is moving his neck, there is some electrical sensation goes back to the back. Okay, this condition is called Lindmeier sign. It is more positive in case of cervical myelopathy or B12 deficiency or multiple sclerosis as well. So the treatment will be the prevention of further neurological deficit. There could be surgical decompression is the most important treatment in case of myelopathy. Okay, radiation is not having any role in particularly cervical spondylotic myelopathy. It is more useful in a case of radiosensitive neoplasm. Steroid may be useful in traumatic spinal injury, but this is not that much important. But steroid is particularly indicated in neoplastic cord compression. We should remember about neoplastic cord compression, use steroid. The next question. The next question is for a 59 years old man from Cape Town presents with a progressive loss of extremity weakness. Okay, so he's definitely from Cape Town, present with progressive loss of extremity weakness that is associated with numbness and paresthesia involving the both legs. So extremity weakness, numbness, paresthesia, with bowel bladder involvement, having the history of diabetes, hypertension, COPD, understanding the intermittent, long-standing the use of steroid with prostatic carcinoma, meds to lower thoracic spine. Treated with radiation, MRI shows T2 hyperintensity in the thoracic spinal cord, no evidence of compression or extradural mass. Okay, so whenever we are getting a patient with having myelopathy, the patient having typical involvement with bladder involvement, bowel involvement, there is a T2 hyperintensity in the thoracic spinal cord, so there's some myelopathy as well. So there is no compression, no extradural mass. Whenever we are not getting an extradural mass, so the possibility of epidural lipomatosis is a less possibility. Okay, epidural lipomatosis is a condition which whenever we use a long time steroid, we might be getting an epidural lipomatosis. As there is no steroid, so that could be lesser possibility. Now the conjo is another possibility. It's an abrupt spinal spastic paraparesis with visual acuity. In that condition, there is an increased cassava intake. It's a very bad toxin, right? It's a conjo. So the patient is having spastic paraparesis. That could be a possibility, but it is not that much, acute onset. It's an abrupt onset. That is very important in conjo. The patient will be having the visual acuity loss as well. So the conjo is also lesser possibility. Third important thing is that it could be epidural lipomatosis. Okay, I've told lathyrism. Lathyrism is a subacute onset spastic paraparesis. So there could be associated with sometimes the particularly intake of Lathyrus sativus. So there is a very lesser possibility of lathyrism nowadays. Okay, so we are considering about the lathyrism as well. But most important thing is that the patient getting radiotherapy. Whenever a patient receive radiotherapy, there could be some myelopathy as well. Okay, so there is two possibility of myelopathy. One is a transient myelopathy, another is the delayed myelopathy. As the patient is having progressive weakness, numbness, paresthesia for about how many? For about 12 months prior to radiotherapy. So we're getting a long time condition. So transient myelopathy is 3 to 6 months after radiotherapy. And the long-standing myelopathy, there will be after 6 months of radiotherapy. Okay, so it is delayed myelopathy. That could be a possibility, another possibility, as the patient having radiotherapy for greater than 6 months. Okay, so it's most likely delayed radiational myelopathy. The patient having radiation to the spine with the development of radiation-induced myelopathy, there is two types of radiation-induced myelopathy, and is transient, another one is delayed. Whenever we're talking about the transient myelopathy, it's about 3 to 6 months after the radiation treatment. The patient present with dysesthesia in the extremities eventually resolved without sequelae. So it is eventually resolved without sequelae, the transient myelopathy. Whenever we're getting a patient of the delayed myelopathy, they will tend to become insidious. There will be paresthesia, dysesthesia, could be having a Lirmite phenomenon as well. Okay, so MRI will get a T2 signal in the affected organ. There could be associated with heterogeneous gadolinium enhancement. Okay, so the issue is that we can give, in case of delayed radiation-induced myelopathy, we can give steroid. But most important thing is that key treatment is minimize the radiation dose. The radiation dose should be minimized. Okay, so lathyrism it's a neurotoxin. We can patient with subacute spastic paraparesis caused by Lathyrus sativus. Okay, it's a chickpea or grass pea. Okay, so they can having a toxin. They have the lathyrism. Okay, next is conjo. Conjo is a spastic paraparesis, particularly more common whenever we poorly processed cassava. That could be a possibility in this case that contains cyanide. Okay, more common in the poor population, just like the lathyrism. Okay, another thing is that whenever you're using the chronic use of steroid, so chronically there is hypertrophy of the extramedullary adipocytes. So the patient is having epidural lipomatosis, but the patient is having the MRI showing there is MRI of the spine. In that case, there is some fatty tissue in that condition. Okay, there's a fatty tissue, but here the MRI typically not showing any fatty tissue corresponding like epidural lipomatosis. Now, this condition, a patient evaluated for progressive spastic paraparesis, also having anemia, also having leukopenia, B12 normal, folate, I guess it is lower normal, copper, I guess normal as well. Okay, which one of the following is the correct treatment? Okay, first, no therapy is needed since the test letter is within normal limit. But patient is certainly not within the normal limit, right? The patient, we should start zinc supplementation. I guess there is no issues regarding zinc supplementation as well. Folate supplementation, not now. Copper supplementation, okay, the copper is within the normal limit, I guess. So the possibility, whenever we're suspecting a patient of B12, the patient is having anemia, the patient having leukopenia, there could be a lot of things we should remember. Okay, there could be copper possibility, there could be B12 lesion as well. Okay, sometimes the B12 level is normal in a case of myelopathy as well. So we should check of other feature as well. Whenever we want to confirm it, we should check about other feature like methyl malonic acid or homocysteine level as well. So in this condition, it's a myelopathy with hematological disturbance. There could be two possibility. It could be B12 or copper. They can both having these sorts of problem as well. Okay, as the methyl cobalamin or B12 as a cofactor for methionine synthesis. Okay, and as I discussed earlier, in that reaction, the homocysteine will be converted to methionine. Sometimes B12 level can be normal, but wherever the methyl malonyl and homocysteine is not, in a patient B12 normal with myelopathy, we're getting abnormality of homocysteine or methyl malonyl acid, you should think of B12 deficiency as well. So, folate deficiency can lead to neurological disturbance like those seen in the B12 deficiency. However, this is less frequent and less severe. Okay, the patient may have the B12 and folate deficiency. So whenever we treat only the folate deficiency, the hematological condition will be improved, but the spinal cord won't be improved. So we should remember, whenever we are treating the patient with folate, we treat with B12 also. Okay, so we should remember this fact as well. So, as I told earlier, the copper deficiency can have a similar clinical manifestation. However, this is less frequent, very, very rare in compared to that. And the copper level is borderline low. In this case, there should be, follow-up in the further aspect. Why zinc is important? Sometimes we're treating the patient with zinc. Zinc can leads to decreased absorption of copper because zinc induces the synthesis of melanothionein in intestine. Okay, so since copper is having high melanothionein, they both enter the enterocytes and they eventually sloughed off in the mucosa. So that then it leads to loss of the copper. Okay, so whenever we're giving the zinc, we are losing the copper. So whenever the long-time zinc supplementation can be associated with the copper deficiency as well. Now the Cleveland, a 33 years old man from the Cleveland with unknown past history presents in the hospital in July. The July is very important. Remember this fact as well. There will be fever, there's mild lethargy, there's bilateral lower extremity weakness that progress for the 5 days. Okay, the patient is confused with flaccid quadriparesis areflexia. So a GBS-like feature. Okay, so Cleveland patient, July is very important, having a GBS-like weakness. So think about West Nile. Okay, so West Nile is a very important, it's a flavivirus. So it's a flavivirus, undoubtedly. So it is transmitted by mosquito. This is the illness having meningitis, encephalitis, having myeloradiculitis as well. Sometimes there could be fever, having typical GI symptom. Okay, there will be back pain, having a GBS-like feature. We should think about the typical West Nile virus involvement. Okay, so sometimes we should check about the CSF antibody. We should check about the CSF PCR in order to get a proper diagnosis. The MRI can have the myeloradiculitis, having the chorda equina involvement as well. The most enterovirus and herpes virus, that particularly the herpes virus, they may have an involvement of transverse myelitis, which is a typical post-infectious phenomenon, but there is no features of transverse myelitis in this case. Okay, polio is enterovirus. They can have a reflexive flaccid paraparesis due to damage of the enterohome cell. Okay, but the polio typically not involving any central nervous system involvement. The patient does not have a history suggest HIV. Okay, sometimes the HIV is very important. The patient, the HIV causes the progressive myelopathy characterized by spastic paraparesis with impaired vibration and proprioception sensation with sensory gait ataxia, as I told earlier. But the most important thing, there will be vacuolar myelopathy. Myelopathy from HIV is a late presentation, does not seem to be the case here. Okay, another important thing, human T cell lymphotopic virus, it can be transmitted by sexual, can be parenteral, can be maternal. Okay, a lot of condition could be affected. In that condition, the myelopathy will be having a particular predilection to thoracic region. Particularly, there will be neuronal loss, there could be microvascularization, there could be long-term degeneration as well. Now, next question. A previously 36 years old woman presented with rapidly progressive flaccid paraparesis. So there is rapidly flaccid paraparesis. She recalls an episode of right eye visual loss 2 years ago, which resolved without treatment. Okay, so the MRI shows a large T2 hyperintense lesion extending from T5 to T11. The MRI shows a few scattered, non-specific white matter lesions. The ESR elevated, ANA positive, CSF shows an inflammatory feature as well. There is normal IgG, no oligochondral bands, and which one of the following is more common condition as well. So we get a patient with optic involvement 2 years ago, which recovered, having a longitudinal extensive transverse myelitis. So the patient having the progressive paraparesis could be due to, I guess, spinal shock. Okay, so in this condition, we should think of a condition named neuromyelitis optica. Okay, so let's check out the condition. Neuromyelitis optica is a antibody against aquaporin 4. Yes, it could be a possibility. Neuromyelitis optica, ANA positive, not likely to be we should think about the SLE because other feature as well. The Caucasian is more frequently affected. Pathological analysis of the spinal cord demonstrate a demyelination. Aquaporin 4 is it works on astrocyte, I guess. So I guess it's A could be the best possible answer. The neuromyelitis optica or David disease is a inflammatory demyelinating condition of the center nervous system, which would involve the optic nerve and the spinal cord. So there could be optic neuritis and spinal cord involvement causing myelitis, hence the neuromyelitis optica. Okay, so it is 9 times more common in women than in men. It's unlikely multiple sclerosis, tends to involve a Asian or African population as well. Patient will present a combination of neuritis and myelitis. The myelitis will present acutely as a longitudinal extensive transverse myelitis, usually involving more than 3 segments. Okay, so the MRI shows a T2 hyperintensity with GAD enhancement. The brain MRI shows a white matter changes. However, these changes are non-specific, non-diagnostic for multiple sclerosis. That's very important. With these features are non-specific, okay? In case of multiple sclerosis, there will not be any longitudinal extensive transverse myelitis as well. So sometimes there could be some brain changes, because aquaporin channels are common in the brain stem and hypothalamus, so there could be some brain involvement as well. Okay, the CSF is frequently abnormal. They're showing the increased WBC, increased protein, normal glucose. Oligoconal band rarely present in CSF. In contrast to MS, the pathological analysis of the spinal cord will show a inflammation and demyelination as well. So in this condition, the neuromyelitis NMO IgG antibody is pretty important in order to make a diagnosis. It's a sensitivity of 64, specificity of 99. So that is very important. Whenever the positive, it's a very important thing we should consider. Okay, this antibody is directed against the aquaporin 4, a protein. They involve the astrocyte food processes of the around the cerebral microvessel located in the blood-brain barrier as well. A majority of the patient having non-specific seropositivity to autoantibody, particularly the ANA, but we should not think about it is SLE. We should think in a typical pragmatic way about the neuromyelitis optica. Okay. Now the next question, it's a very important question as well. I will omit the answer. We'll think about that, whether it is adrenoleukodystrophy or not. So a 34-year-old man having progressive neurological manifestation. He was a normal child and adolescent. He was fine up to 23. Then he started noticing numbness and tingling numbness involving the fits and difficulty in running. He has been diagnosed with spastic paraparesis, has been getting gradually worse over the first few years, and now he needs a worker to talk. So it's a rapidly progressive condition as well, right? So there is some mild cognitive impairment, there's some behavior issue, there is some hearing problem, there's some vision problem, as well as urinary incontinence. So it's becoming a difficult condition to diagnose. So in the past medical history, it's significant for 5 admission of ICU secondary to upper respiratory infection, leading to significant hypertension and hypoglycemia, for which he required steroid. Okay, so that is the fact. That is the thing that is pointed towards the diagnosis. So we guess there is spastic paraplegia. There is some I guess tingling numbness as well. So spastic paraplegia with tingling numbness, hearing, visual issue. So a lot of condition can have this. But the important thing is that there is hypertension with hypoglycemia, which requires steroid. That will point towards a single diagnosis, that is the Addison's disease. Whenever you got a condition having, fatigue, having, hypotension, having hypoglycemia, requiring a frequent amount of steroid, think of Addison's. So patient having spastic paraparesis, having Addison's, always think of adrenoleukodystrophy. Okay, there is certain adrenoleukodystrophy like condition, particularly adrenomyelode neuropathy. In that condition, it's particularly involving, I guess, very long chain fatty acid. So in this condition, there will be inability to oxidize the very long chain fatty acid. The very long chain fatty acid is accumulated in the plasma, in the multiple tissue. Whenever it is involving it can involve the cerebral white matter. So the cerebral white matter involvement can involve the tract. So there could be bilateral spastic weakness. Also, there could be involvement of Addison's gland. There could be Addisonian feature as well. The patient will be having more feature in particularly age greater than 20 years. So patient having 20 years after onset, having cognitive problem, vision problem, hearing problem, Addison's, spastic weakness, more in feature of adrenomyelodystrophy. Primary lateral sclerosis can explain spasticity, but cannot explain hearing, vision, Addison's. Okay, neuromyelitis optica cannot explain particularly the Addison's. So always think of this peculiar condition as well. So adrenomyelode neuropathy, it is a condition of adrenoleukodystrophy. It's particularly involving the ABCD gene of chromosome 18, okay, which involving a Parkinson protein that is very important. And due to this mutation or due to this problem, patient will be unable to oxidize very long chain fatty acid, particularly hexacocyanoic acid. Okay, the hexacocyanoic acid will be accumulated in a big enough. The patient having these sorts of symptoms that is typically explaining this condition. Okay, so the issue is that patient having very long chain fatty acid, it's important. So sometimes we can, do a plasma, check the level of very long chain fatty acid in the plasma. We can check the fibroblast. That is very important. Patient may record steroid quite well for adrenal insufficiency. This medication has no effect in the CNS improvement. Had no effect in the CNS involvement as well. Now, the next question. A patient present with several months history of gradual progressive sensory loss to pain and temperature over the shoulder and bilateral arms with preserved tactile touch, vibration, and proprioception. On examination, there is multiple old injury in the upper limbs. He has weakness, atrophy, minimal findings in the lower limb as well. Okay, so as you can see, there's sensory loss and pain and temperature. I guess that makes the diagnosis. So there is sensory loss in the upper limb, okay, with preserve the dorsal column. There is multiple injury, as there is no pain temperature sensation. He will get injured and will not recognize because there is no pain. Okay, so there is a cape-like sensation. So this is typically of syringomyelia. Okay, so we should think about syringomyelia. We should not talk about the other option as well. The patient having dissociative sensory loss, the sensory loss will be the pain and temperature. There will be preservation of the tactile touch, vibration, and proprioception in the upper extremities. This clinical symptom is typically seen with central cord lesion. Okay, whenever you got a patient with syringomyelia, there could be cape-like sensation, there could be shawl-like sensation. It will not affect the posterior columns. Okay, because the posterior column, there will not be any affection of the syrinx expansion. If the syrinx unfortunately expands posteriorly, there could be a patient will be involving the posterior column involvement as well. So this dissociative sensory loss could be found in syringomyelia, could be found in anterospinal artery occlusion. Okay, in case of syringomyelia, the cavitation will be involving, as you can see, the central part of the spinal cord, particularly the cervical region, that will extend upward to the brainstem. If there is upward extension, that could be syringobulbia. We should remember the syringomyelia can have a condition that's carry-on malformation. Okay, so it could not be explained by Brown-Sequard syndrome, that could not be explained by subacute combined degeneration, could not be explained by other condition as well. Now, the next question. What is correct regarding the neoplastic disease of the spinal cord? So whenever we talk about the neoplastic disease of the spinal cord, what we should remember? Okay, so there's certain information we should remember. We should memorize this condition. Whenever we're giving some board exam, these are the high fact regarding the malignancy of the spinal cord. So corresponding the most common diagnosis, that is the spinal cord metastasis. So metastasis is more common. The commonest cause of metastasis is from the small cell carcinoma of the lung. Second is the breast carcinoma. Third is the renal cell carcinoma. Fourth is the other condition like lymphoma, melanoma, other. Okay. Second, in case of tumor intradurally, we can divide it into two parts, particularly the intradural extramedullary and intradural intermedullary. In case of intradural extramedullary, commonest is meningioma. Intradural intermedullary, commonest is ependymoma and astrocytoma. That concludes the factor as well. So the first important thing, correct option that we are searching for. Oligodendroglioma is most common intramedullary spinal cord tumor. Okay, no, it's the ependymoma and astrocytoma. Astrocytoma is the most common intradural extramedullary. No, it's intradural intermedullary. Intradural extramedullary is commonest. We should think about the meningioma. Okay. Another important thing is that most common intermedullary meningioma is absolutely wrong answer. Okay. Another thing important, myxopapillary ependymoma originate from the phylum terminally. I'll talk about this later. Intermedullary spinal cord metastasis is the commonest primary intramedullary neoplasm. Okay, so I guess it's more common in the myxopapillary ependymoma originate from the phylum terminally. We should remember the fact. Just 1 minute. Now, neoplasm of the spinal cord could be primary, could be metastasized. They can divide particularly anatomically into extradural or intradural or extramedullary or intradural intermedullary. The primary neoplasm account from the intradural spinal cord metastasis that include the small cell carcinoma of the lung. They can involve the breast carcinoma, renal carcinoma, lymphoma, melanoma. Okay, but the issue is that meningioma is commonest intradural extramedullary tumor having the predilection of thoracic spine. Okay, we should remember about the thoracic spine. Should not forget that. Another thing is that other tumor are schwannoma. Okay, or it could be neurofibroma. They are also intradural extramedullary. Okay, and the most frequent intradural intermedullary tumor are ependymoma and astrocytoma. Astrocytoma are commonest in the children. They are the low-grade tumor. Ependymoma is the most common in the adult. So always we should remember astrocytoma in children, ependymoma in adult. How we should remember? Because astrocytoma comes with A. So in young age, there could be astrocytoma. Then A, B, C, D, E. In the advanced stage, there is E, that means ependymoma will be the most possible answer. So another ependymoma is a myxopapillary ependymoma. They develop from the phylum terminally as well. It's another common tumor in this location. Okay. Now, another important thing, a 12-year-old girl, no family history, febrile illness, associated with the headache, altered mental status, inability to move the legs, incontinence. She's confused. There is no meningeal sign. There's flaccid paraplegia with adreflexia with sensory loss. And whenever we got a case of a flaccid paraplegia with adreflexia with sensory loss, we should think about cord compression with shock. Okay, so there's myelopathy with shock. So that why there's myelopathy, there's sensory level. Why there is shock, there is adreflexia. That's why. So this is the case of myelopathy. Okay, but that doesn't, the situation doesn't end here. The patient having sinus involvement also. The patient is having, the CSF feature. The patient is having some increased protein. So inflammatory brain changes, having very high IgG index. Okay, so there is also subcortical white matter lesion as well. So there is brain white matter involvement as well. Okay, so whenever we're getting a case with brain involvement also spine involvement. Why? Because there is also a longitudinal extensive cord involvement. So there is cord involvement with brain involvement. Both involvement is there. So we should not think it as myelopathy. We should think it's ADEM. Why ADEM? Because acute onset, brain involvement, cord involvement with patient is having a febrile illness after the onset of febrile illness. So monophasic myelopathy, encephalopathy after febrile or vaccination, we should think about acute disseminated encephalomyelitis. It's a monophasic condition. So acute disseminated encephalomyelitis, it is a demyelinating disease of the childhood. There is monophasic immunogenic reaction to a viral illness. Patient will have an encephalopathy, confluent white matter changes in the MRI, and there could be some inflammatory changes ongoing in the CSF. Occasionally, there is a feature of transverse myelitis. We should not say it's transverse myelitis as there is CNS involvement. Okay? And it is longitudinally extensive transverse myelitis. The important feature is that we should give steroid in this patient in high doses, particularly in the form of methylprednisone. And the patient is having encephalopathy, is not a feature of NMO. Multiple sclerosis should not be present like a situation like this, having extensive nerve involvement, longitudinal extensive, having brain involvement. It's not typical for multiple sclerosis as well. Okay, acute encephalopathy is also uncommon in MS. Okay, so patient could be diagnosed as idiopathic transverse myelitis, but issue is that there is white matter changes in the brain as well with encephalopathy. So you should not diagnose a case with isolated transverse myelitis. So it is ADEM. Okay. Now, next question. A 50 years old man present with gradually progressive weakness in the upper extremity. The cervical MRI is obtained and shown in figure 11.4 based on the localization lesion, which what will you find here? Okay. So as we can see, there is a 50 years old man. There is a progressive weakness in the upper extremity for about last 6 months. MRI shows there is some issues there in the upper extremity as well. What are the issues there? As we can see, there is a, there is some signal changes ongoing. This is cervical 1, 2, cervical 1, 2, cervical 3, 4. So I guess it is a 2 to 4, I guess. There's some cervical lesion in the upper part. So what will be the finding? There could be patellar and ankle aliflexia. It is not acute, so there will not be shock. So there could be hyperreflexia. Sensory loss below the line of nipples. I think it will involve a further upper value will be involved. Spared abdominal reflexes, flaccid weakness in the extremities as well. So I guess the best answer should be confirmed here. So there should not be any flaccid weakness. There should not be any sensory patellar or ankle areflexia. There could be sensory involvement, but I guess nipple is a bit lower level. The level should be a bit higher, I guess. Horner. Let's take that answer. So Horner syndrome could be a possibility. Okay. So the Horner could be the best possibility. So we should remember that whenever the Horner syndrome is particularly involved in a patient with spinal cord lesion above T1. Okay. Okay. So Horner syndrome should come out in a spinal cord lesion in above T1. As there is the lesion is above TC segment, there will be absence of superficial abdominal reflexes. So whenever you got a lesion above T6, there won't be any as there is the lesion over the T6, there will be absence of the abdominal reflexes. That could be the best possible answer. So Horner syndrome. Typically, you should remember, Horner syndrome is particularly present in a spinal cord lesion above T1. Okay. Sometimes, the spinothalamic tract synapse before the exiting the spinal cord as well. This is the upper cord lesion, particularly involving the C1 to downwards. Okay. So this is typically involving the Horner syndrome could be affected. Okay. So one thing we should remember, in the upper spinal cord lesion, particularly involving the more than T1, there could be associated Horner syndrome. Okay, so the loading jar will be accelerated. All those things will be accelerated. The sensory level will be much higher than nipple, as I told earlier. The absent superficial reflexes is more common in the lesion above T6. In the below T6, there will be superficial abdominal reflexes will be spared. Okay, so as the lesion is developed gradually, patient will likely to develop the myelopathic finding, particularly the upper motor neuron. So there will be increased tone with spasticity, with hyperreflexia below the level of the lesion. That is very important. Second thing is that a sensory will be helpful for localization of lesion. And the sensory level is correspond to T4, but the lesion is much more higher. So I guess the lesion will be much more higher. Okay. And third important thing is that the presence of abdominal hip reflex is a very normal thing. Their absence indicate the lesion above T6 level. Okay. Abscess abdominal reflex, think about above T6. Now, a very important thing that will involve the atlantoaxial dislocation. A lot of condition can have this atlantoaxial dislocation. We should know about these symptoms as well. So rheumatoid arthritis is an important cause of atlantoaxial dislocation. Down can cause it. Kipple can definitely cause this syndrome as well. So the issue is that we should think about the systemic sclerosis and more quiz. So I guess it's more likely to think we should think about the SLE as a cause of the atlantoaxial subluxation. So whenever we think about atlantoaxial dislocation, we should think about certain condition as well. Okay, the ligament of the atlas and axis or the odontoid process, very important to maintain the stability. Okay, so the odontoid process, particularly, or the ligament, the articulation, if that is failed or odontoid process is absent or damaged, there will be atlantoaxial dislocation. The patient will having some neck pain, having some quadriplegia. They can involve the death also, particularly involving the respiratory center also. So always think of the condition, particularly the rheumatoid arthritis. The Down can have this, the Morquist can have this, and particularly the Klippel-Feil. Okay, it's a very important condition. Klippel-Feil syndrome, we get a lot of cases sometimes in the world, so it can also cause a atlantoaxial dislocation. So the Klippel, other condition of rheumatoid arthritis is known to have a destructive inflammatory process in the ligament attaching the odontoid process. They can have the dislocation. Also, the Klippel-Feil can have the dislocation. Down syndrome can cause the dislocation. Okay, and Marquez syndrome is a skeletal disorder. They have the odontoid process to be absent or aplastic. They can have this sorts of problem as well. Now, another important question regarding the spinal cord neoplastic disease, what should we think? First important thing is that extramedullary tumor include ependymoma and astrocytoma. This is wrong. The intramedullary tumor containing the ependymoma and astrocytoma. Intermedullary tumor causes cord compression. That is the astrocytoma and ependymoma. The neurofibroma, meningioma, soma, they are the extramedullary intradural tumor. Okay, the malignancy that may metastasize to spine, they arises from the breast, lung, prostate, kidney. That could be a possibility. Okay, radiation therapy, no role. It's absolutely wrong. A protocol of high-dose intravenous methylprednisolone continuously for 24 hours, not 24 hours at least. So the possibility is C, I guess. So neoplastic spinal cord is an intrinsic to cord or metastatic disease. Tumor affected the spinal column or spinal cord divided into, as I told earlier, extramedullary or intermedullary. The extradural or interdural. They could be further, interdural could be further classified into intermedullary, extramedullary. All this tumor can be classified into metastatic or non-metastatic. Okay, so commonest extramedullary tumors, they include the meningioma first. Second come neurofibroma, sonoma. Okay, the metastatic disease could be from most likely from the lung, breast, prostate, thyroid, kidney. A lot of condition could be there. There's some there could be some myeloma or multiple myeloma or lymphoma. That could be another possibility as well. Okay, the patient may having the pain or focal neurological deficit that could be associated. Okay, the patient, we should do a MRI with CAT, that could be very important. Steroid are frequently used. They're having a bolus treatment could be given there. Radiation therapy could be important for non-radiosensitive tumor as well. Sometimes the germ cell tumor or lymphoproliferative tumor, they have a very good radiotherapy response. Okay, sometimes there could be some palliative measure as well. Surgical resection could be feasible sometimes as well. Now, the next question. A 27 years old man having a motor vehicle accident has been ejected from the car. He suffers from acute spinal cord injury, cord transection, very unfortunate, in C5-C6. Which one of the following will be present in the first week, except? Okay. So which one will be not present, right? So first of all, there will be flaccid weakness. Okay, the patient having acute cord transection, it could be a possibility. There could be atonic bladder, overflow incontinence, that could be a possibility. Okay, there could be decreased renal tone, that could be an issue. There could be patellar or ankle areflexia, there could be spontaneous reflex defecation. So considering there's some defecation center as well, so I guess it's most likely spontaneous reflex defecation. So spinal cord tremor is a significant cause of myelopathy and common cause of severe disability after trauma. Yeah, yes, right. No. Sometimes we give steroid, but not that much. Okay, the guideline doesn't recommend steroid in the hardest form. Okay, so spinal cord trauma is a significant cause of myelopathy and common cause of severe disability. That is very important. So spinal cord trauma is a significant cause of myelopathy and is one of the commonest cause of disability after trauma. It's particularly more common whenever in the patient with adult. Okay, sometimes there are sometimes the cord could be tethered, the cord could be damaged, the cord could be transected, so patient will having a lot of problem after the cord transection. So after the spinal cord injury, there is two phase. Sometimes the initial phase of spinal shock, and they will follow the reflex activity with spasticity. So spinal shock recover, they can persist a few weeks, between 1 to 6 weeks could be there, but there is no exact time limit of the spinal shock. Okay, we could not predict that how much the spinal shock will continue. In complete spinal cord injury, patient will having a flaccid weakness with areflexia. Okay, there could be atonic bladder, there could be overflow incontinence, there could be decreased anal tone, there could be decreased peristalsis, there could be abolished genital reflex, there will be constipation. All the factors can present there as well. In particularly few weeks later after spinal cord injury, patient will started presenting a increased reflex activity below the level of the lesion. The lesion that will previously having the spinal shock, they will present like a upper motor neuron feature as well. So in the second stage, there will be upper motor neuron findings with increased tone leading to spasticity, hyperreflexia. These are the features. The plantar response are upgoing, triple response sometimes occur as well. The patient having detrusor spasm, hyperactivity, urinary loss, spontaneous bladder contraction as well. Okay, so but the issue is that neither spontaneous reflex defecation nor detrusor contraction, they could be present in a spinal shock phase. Okay, so patient who will having the detrusor spasm or hyperactivity, they can having a spontaneous bladder contraction or spontaneous reflex defecation as well. Okay, we have seen the answer, but that doesn't, inhibit us to solving the question as well, right? A 55 years old man having a slowly progressive grade ataxia. So he's having ataxia, myelopathic findings, and mild cognitive impairment present in the follow-up. So there is a grade ataxia, myelopathy, cognitive impairment. He has a diagnosis of superficial siderosis in the CNS. So we should remember the diagnosis superficial siderosis. So which one of the following is incorrect? First off, there is the sensorineural diagnosis, deafness is very important. It's absolutely true. A lot of patients with superficial siderosis will be having a sensorineural type of hearing loss as well. So source of hemorrhage is not identifiable. Okay, in many of the cases, we'll be unable to get a diagnosis of, what are the source of bleeding in case of superficial siderosis. So the source of hemorrhage is sometimes, unidentifiable. It's absolutely true. Third important thing is that the CSF, there could be bleeding, so there could be xanthochromia as well. So there could be hemosiderin deposit in the subpial layer of the brain and spinal cord. That could be a possibility. T2 hypertense, I guess that will be the answer. Okay, so superficial siderosis is a condition that could be, if there is some, the bleeding could be some risk factor like some hemorrhage, some head trauma, some previous surgery as well. Okay, but issue is that sometimes the most important thing, what is the source of bleeding, is very much difficult for us to determine. Okay, so the bleeding source is undetermined, but sometimes there could be some risk factor as well. But the issue is that there is bleeding, there is hemosiderin deposit, in particularly the subpial layer of the brain and spinal cord. The patient is having a lot of problem regarding to that. So what are the problem? First of all, there will be ataxia. There will be sensorineural type of defecation. Sorry, extremely sorry. So there could be sensorineural type of hearing loss, the deafness. Okay. Sometimes there is anosmia, cognitive decline, and myelopathic feature as well. But we should remember, in a patient having hemosiderin deposition, corresponding ataxia, corresponding sensorineural deafness, with cognitive impairment, should think of this condition having superficial siderosis. Whenever we did a MRI, as there is bleeding T2 hypointensity, there will be there in the brain stem or spinal cord as well. Okay, if a possible etiology of recurrent bleeding could be found, there could be surgical repair or endovascular repair. They should be ensured. But issue is that whenever the approach has been done, whether it will hold the progression of disease, this is a bit unclear. Now, syphilis. Syphilis is a very important thing we should understand. Okay, particularly the syphilis can have a lot of condition in our body, particularly in the nervous system. Okay, so we are dealing with syphilis in the nervous system. Whenever a person contracts with syphilis, the patient will having the first stage. In the first stage, he or she will develop the typical chancre, which is the painless ulcer having absolutely painless lymphadenopathy. In the next step, you will develop a disseminated infection in the body that is known as the condylomata lata. Okay, a lot of part of the body will be involved. The patient will be having this is the secondary syphilis, right? In case of secondary syphilis, there could be meningitis also. Sometimes the Slane-Tack ulceration also. In case of tertiary syphilis, there is a lot of form involving. It could involve the meningovascular form. So whenever it involves the meningovascular form, patient will come to us with stroke. The features of a stroke could be present there. Okay, so it could be involving the dorsal column. The patient will come to us with dorsal column involvement causing tabes dorsalis could be there. Okay, so in that condition, patient will be having prominent ataxic symptom. Okay, with sensory ataxia, also having maybe a recurrent injury causing Charcot joint as well. So that's ataxic tabes dorsalis. That could be a possibility. Sometimes there could be, apart from this ataxia, there could be some, nervous system involvement as well, particularly the motor tract. So whenever the motor tract will be involved, there will be spastic paraparesis with autonomic dysfunction, sometimes sphincter dysfunction as well. So one thing is ataxic, the tabes dorsalis. Second thing is sometimes paralytic, having spastic paraparesis, and sometimes the patient having severe lancinating pain in the leg, having sexual dysfunction. That is the pre-ataxic form as well. Okay, so the syphilis can have tabes dorsalis, can have taboparesis, can present to us with stroke, having the meningovascular syphilis as well. So first of all, we need to choose the correct answer. The anterior column of the spinal cord is affected. It's absolutely wrong. It is particularly affecting the dorsalis. There is a dorsal column. So the posterior column is typically affected. The patient with tabes dorsalis will be involving the dorsal column involvement with sensory ataxia. So this is wrong also. So the Charcot joint is not due to the spirochete invasion. It is due to the proprioceptive loss causing recurrent injury and problem. Okay, so the treatment of neurosyphilis, it's not right, I guess. And the meningocovascular syphilis, as I told earlier, the patient can present it to us with stroke. Okay, so that will be the best answer. So as I told earlier, it is a spirochete, Trypanosoma pallidum, associated with wide variety of neurological dysfunction. First of all, it can having the myelopathy. It can cause cord infraction in meningovascular syphilis. The patient having tabes dorsalis, having classical myelopathic syndrome. Okay, also having the posterior column involvement. Posterior column involvement causing sensory ataxia and proprioceptive loss. Okay, the issue is there. Okay. There could be some Learmite sign, lancelating pain with areflexia. So the issue is that there is three forms: the pre-ataxic, ataxic, and post-ataxic. In case of pre-ataxic, there will be some lancelating pain with some sphincter disturbance. In the ataxic, there is some dorsal column involvement. In the post-ataxic, there is spastic paraplegic autonomic dysfunction. So these are the three factors. Okay, so it can involve the spinal cord disease by a lot of phenomena. We should treat the patient with penicillin G IV for about 14 days. 14 days treatment is very important in case of syphilis. Now, patient having, the patient having pelvic cancer, severe radicular pain in the perineum, radiate to both legs, with asymmetrical presentation. So severe radicular pain, asymmetrical presentation, having asymmetrical sensory deficit, having areflexia, having bowel bladder, I guess there is no bowel bladder involvement. So there's some sensory deficit in the perineum as well. So I guess it's most likely to involve the cord equina. So I guess it's most likely to cause cord equina syndrome. The conus medullaris can have the lower part of the spinal cord, but this is typically in case of conus medullaris, there will be sensory deficit in saddle anesthesia. There will be symmetrical involvement, bilateral in the motor involvement. There could be some upper motor sign with lower motor sign with upgoing plantar could be a presentation in case of conus medullaris. But chorda equina, on the other hand, it's a radiculopathy. It's absolutely non-motor. So evidence of areflexia or hyporeflexia with asymmetrical sensory bowel bladder troubles could be a presentation in chorda equina features. So it's a neurosurgical emergency. Okay, this is the condition can cause compression, irritation, or infiltration of the fiber. Okay, you should remember it can be caused by the trauma or hematoma or tumor, as well as TB, cytomegalosarcoidosis itself. Now, a 56-year-old woman referred to clinic for the evaluation of the suspected amyotrophic lateral sclerosis. Her history and examination are most part consistent with ALS, but there is rapidly unexpected weight loss, calcium is slightly elevated, and chronic neck pain. So typical ALS-like feature, upper motor, lower motor mixed. Okay, there is neck pain, calcium elevated. What you should do in this case, right? So there is calcium elevated with ALS. So whether you should do a EMG NCS, whether you should do anti-WHO, whether you should do a parathyroid, I guess it's a paraneoplastic phenomenon. That could be a possibility here. We should do in this case at least anti-WHO, a parathyroid level as well. Okay, also EMG NCS, we should check about that. So I guess the parathyroid related protein could be an issue here. So the diagnosis of ALS, sometimes we should do a ALS scoreal criteria. The most important fact is that the evidence of upper and lower motor neuron, at least 3 of the 4 regions, like bulbar, cervical, thoracic, lumbosacral. Okay, so there could be 3 out of 4 reason ALS involvement. So there could be electrodiagnostic feature as well. Sometimes we should do, whenever we want to do a EMG or NCS, in case of we should get some issues as well. So reduced motor recruitment with rapid firing in EMG. There is some spontaneous activity with chronic denervation. There's some issues in the ALS ongoing, right? So sensory NCS is normal. The NCS EMG evaluation of suspected ALS should be there. The differential of the ALS could be very broad. Okay, whenever we are evaluating a patient of ALS, we should think about other condition as well. Particularly sometimes McArdle variety, There's the spinocerebellar ataxia type 3, adrenooligodystrophy, multifocal motor neuropathy, hyperparathyroidism. Even some, sometimes we should think about the lysosomal disorder, right? GM2 ganglioside, polyglucosan Brodley disease, paraneoplastic disease, the HIV, okay? Western infection, we should remember. Sometimes paraneoplastic issues should be think as well. The MRI, ALS, they show some issues as well. So that could be a complicated question. This is a complicated question, I guess. Now, a 45 years old morbidly obese patient, gastric bypass, came to clinic 3 years after that, having lost about 60 kg. Oh, that's very good. So now she's complaining difficulty walking. On examination, she manifests myelopathy, spastic gait, sensory ataxia. There's anemia, neutropenia, normal B12, but very high methyl malinoic acid. Okay. The issue is that after treatment of B12 doesn't improve, okay, you suspect the copper deficiency. Which one of the following is associated with copper deficiency? Okay, I have told about this earlier. First of all, reduced zinc will not make copper deficiency. Increased zinc can cause copper deficiency. So this is the incorrect information. The copper deficiency may coexist, as I told earlier. They may coexist with B12 deficiency. The optic nerve involvement can be caused by copper deficiency. That could be a possibility. Peripheral neuropathy can be there. So typical B12-like feature. There could be optic nerve involvement. There could be peripheral neuropathy. There could be cervical cord involvement. These are the features. But issue is that the reduced zinc is the most important fact. Sometimes we should remember copper is a trace element that having a particular role in the structure and function of the central nervous system. Whenever we are having a deficiency of copper, they can have a myelopathy in typical B12 deficiency. They can have multiple neurological manifestation. They can have a peripheral neuropathy. They can have a central nervous system demyelination. They can have a myelopathy. They can have an optic neuropathy as well. Sometimes they can have, there could be anemia, neutropenia, hematological manifestation. They are quite common. Sometimes there could be left sheep of the granulocytic manifestation as well. So copper deficiency, they can result from malabsorption, most commonly due to gastric surgery and bariatric surgery for weight loss. Okay. Whenever we're treating a B12 deficiency with copper deficiency, okay, so sometimes B12 deficiency, we treated the patient with B12 deficiency, but patient is not corrected. So copper is particularly what we are overlooking. So lack of B12, lack of improvement after B12 deficiency should prompt the evaluation for copper deficiency as well. Okay. As I told earlier, excessive zinc ingestion could contribute to copper deficiency because zinc induces the synthesis of the metallothionein enterocyte. It has high affinity to copper, so it will internalize the copper. They will even shred it out or sloughed out, causing a copper deficiency. Now, next question. 40 years old, complaining inability to lift the arms above the head or climbing stairs. So there's some weakness, right? In the shoulder girdle weakness or hip girdle weakness. So there is some muscle weakness. The issue is there. Sometimes there is also fasciculation. There is postural tremor. Okay. There is a lot of things. It could have a very fast differential. But the issue is that whenever a patient having a motor neuron disease, we're getting the gynecomastia, also family history, okay, we should think about the Kennedy's disease. It is the X-linked spinobulbar muscular atrophy or Kennedy's disease. It is particularly extreme disorder, particularly involving the male, having the fourth decade. It is involving the motor weakness. Whenever motor, muscle weakness will be proximal, there will be lower motor atrophy feature will be there. Okay. Sometimes there could be proximal weakness, bulbar weakness, facial weakness, fasciculation, a lot of things could be there. Okay. So particularly proximal, lower motor, bulbar weakness. But the issue is that whenever we got a patient similar to that and we get gynecomastia, we get diabetes, we get hypogonadism, we get sterility. This is typical of Kennedy's disease by X-linked spinobulbar muscular atrophy. Okay. Okay. So this is typical. I guess it is X-linked recessive. That's why only male are going to be the sufferer predominantly. Second thing is that there is precocious puberty, but the issue is that there is sterility, hypogonadism, and gynecomastia. This will not be associated with precocious puberty. Facial fasciculation is common. They will tend to get involved more in the fourth decade. So there's 40, fourth decade, and Kennedy's. Okay. So how we should remember is that I remember it by thinking that Kennedy 40, Kennedy 40. Okay, so this is typically involving the fourth decade. So Kennedy is the fourth decade person, and there could be a positive trinucleotide repeat expansion in the androgen receptor gene. So that is very important. Okay, so this is the typical mutation. The mutation will be involving the CAG gene, I guess. So there will be typical CAG mutation in the androgen receptor gene. Okay. So that history typically of Kennedy's disease, it is X-linked bulbar muscular atrophy. Kennedy's is typically present in male in beginning of 40s, as I told earlier. Clinical presentation that includes a motor weakness starting from the proximal muscle and also involving the lower motor neuron function with atrophy, hyporeflexia. Tremor, muscle cramps, and fasciculation are quite common in this condition. The fasciculation will involving the face and perioral region. They can have the patient might be having gynecomastia, but the abscess doesn't preclude. But other condition we should think about the endocrinopathies like hypogonad, sterility, diabetes. Okay, as it is excessive, rarely manifest in case of females. So it is mostly the supportive treatment, I guess. Now, some treatment about the spinal cord disease. The spinal cord has a, we are going to think about the incorrect ones, right? So the patient is having 31 pairs, I guess this is the correct option, lying within a spinal canal, ventral to posterior longitudinal ligament. So there is some anterolongitudinal in the front and the posterior longitudinal ligament in the back. Okay, in the adult, it ends at the level of the lower border of the L1, L2. Okay, I guess. There's some two enlargement. First is the cervical plexus, okay, and the lumbosacral plexus. I guess that's okay. The denticulate ligament extend from pia mater to dura mater on both sides of the spinal cord. So these are the lot of information I have. So what is the correct answer? What is the incorrect answer? So I guess it is the first important thing is that we should remember about the two enlargement. The enlargement, particularly the cervical plexus, I guess, is a brachial plexus. It's right. So, oh, I guess it's the B. I'm extremely sorry. So the lies, it is lies within the spinal cord. It is actually dorsal to posterior longitudinal ligament. Okay. It's extremely sorry. It's a very easy one. I mistake. I do have so by mistake. Sorry. Now the spinal cord lies dorsal to the posterior longitudinal ligament. The dorsal longitudinal. This is the containing the vertebral body, pedicles, lamina. The lamina having the arises from the posterior aspect of the body, then fuses posteriorly. So I guess it's the best option. It is the dorsal to the posterior longitudinal ligament. That is the best answer. The intervertebral disc containing the central nucleus pulposus and outer surrounding annulus fibrosus. So there's 31 pair of the spinal nerve, the cervical 8, thoracic 12, lumbar 5, sacral 5, and coccygeal 1. Okay, and ends at the lower border of the L1 or upper border of the L2. Now, this is a very peculiar question. At birth, a male baby is found to have a hypotonic. Okay, the male baby is hypotonic. He is admitted to intensive care unit, has been intubated for respiratory failure, having tracheostomy, noted to have a little movement of the extremity and persistent head lag. Muscle biopsy has been showing this. So, so what is the possibility? So there is a certain condition we should remember about the spinal muscular atrophy. The spinal muscular atrophy could be of 4 types. Okay, the SMA type 1, type 2, type 3, type 4. The type 1, particularly involving the infantile, it is the Warning-Hoffmann disease. The patient will having a less movement, hypotonia, weak thigh, head lag, frog leg posture. They'll having this sorts of syndrome. As the patient is having the, it's infant. Okay, so infant with less movement, hypotonia, frog leg posture, with respiratory involvement, respiratory failure, causing death. This is the SMA type 1. Okay, the second variety is SMA type 2. This is actually, it's a particularly involving the 1 to 2 year as of onset. So patient is having the motor delay, the tremor is still unsupported but having a contraction. So this is SMA type 2. In case of SMA type 3, this is the juvenile onset Krugelberg-Wallender disease. The involving is in the childhood, reduced walking, SMA type 3. And last but not least, SMA type 4. This is particularly involving the third, fourth decade. The patient having the cordyceps, fasciculation weakness, proximal weakness, and the respiratory or the cranial nerve involvement is quite rare. This is the SMA type 4. So I guess this is most likely SMA type 1. Okay, so whenever we get a history, the muscle biopsy is corresponding to SMA type 1. I have no idea. And the SMA type 1 is of 4 types. The first is infantile SMA, that is the Warning-Hoffmann disease. The patient will having some, the fetal movement, neonatal hypotonia with weak cry. This is SMA type 1. The SMA type 1 will having frog leg posture and head lag. The two things you should remember about the frog leg posture and head lag. Whenever you got head lag and frog leg posture, always think of SMA type 1. Okay, the patient will having, respiratory failure. There will be areflexia. The patient will be dead by the age of 2 years. Okay, the intermediate SMA, the one life ends, another begins. So SMA 1 ends, SMA 2 begins. So it begins approximately up to 2 years. The patient will having some motor delay. There's some hypotonia, there's some tremor, there's the patient will be having hypotonia, tremor. The severity will be less. Okay, the most important thing we should remember, the patient will be having significant contracture as well. This is typical SMA type 2. Third important thing is that juvenile SMA or SMA type 3, it is Krugelberg-Wallender disease that particularly involve the juvenile period. So there will be some weakness, hypotonia, contracture, tremor, fasciculation in the juvenile period. The most important thing that is particularly important, the adult onset. Okay, so in this case, that symptom typically begin in the 3rd to 4th decade. That will be proximal muscle, and particularly we should remember the fact cordyceps. Never forget about cordyceps. Whenever you're thinking about the adult onset SMA, think about the cordyceps. But most important thing is that there could be wasting, there could be fasciculation, but we should remember the core fact is that there will be lesser involvement of respiratory muscle, there will be lesser involvement of cranial nerve. So patient will be having a good life. Okay. So the cranial nerve and respiratory nerve involvement will be rare. So sometimes the CK could be elevated. Sensory ENCS will be normal. The EMG shows the innervation, denervation with large polyphasic motor unit compatible with the myopathy. Okay, so there's some muscle atrophy as well. So other possibilities here. In case of SMA, we should remember about the inheritance. Okay. Okay, so spinal muscular atrophy type 4 present in the adulthood, Charcot-Marie tooth in the childhood. This is another issue, and congenital myasthenia botulism. These are other issues as well. So, a patient with obesity, hypertension, diabetes, gastric bypass surgery with having inhaled anesthetic during the procedure as well. Around the 5 days after the surgery, he noticed that cannot move the leg, having stress sensation below the waist. There is some T2 hyperintensity, extradural collection as well. Okay. So, what is the possibilities here? So the patient is having some, the myelopathy particularly. So copper can cause myelopathy, but not in the short duration. This is short duration. We are thinking about short duration myelopathy. Folate cannot cause short duration myelopathy. Okay. The patient having hematoma can have short duration, abscess can have short duration, but patient is not having any fever, right? So nitric oxide could be a possibility. As we can, we should know nitric oxide having, having the propensity to involve the B12. So there could be B12 deficiency. So nitric oxide toxicity could be a possibility here. So the patient having a nitric oxide toxicity is a neurological manifestation. They cause the anesthesia paresthetica. So whenever just after the inhalation anesthetic agent, patient it irreversibly bind to cobalamin. The patient makes the B12 inactive. So patient drastically cobalamin deficient, rapid onset of symptom. Okay, chronic exposure can lead to similar types of symptom, particularly in the dentist chamber from the occupational exposure as well, right? And patient who is having chronic exposure, it's also, we should remember the fact the neurological features include the myelopathy. The patient is having the MRI feature, the T2 hyperintensity is noted. So in this condition, we should give the patient prophylactic B12 deficiency. So this is not folate, this is not copper, but copper could be possible in the patient having the gastric bypass. It could be malabsorption, but it can develop after years. Okay, so folate deficiency could causes neurological manifestation in a pretty rare instance. Okay, so folate deficiency could be another possibility, but it is a very rare. You should remember, in case of epidural abscess and hematoma, the patient having the spinal cord compression, in this condition, it is not present. Okay, as you can see, the MRI shows the T2 hyperintensity. There is no extradural collection. So there is no extradural collection. Confidently exclude the spinal epidural hematoma or epidural abscess. Now, 18-year-old man originated from Hawaii, presents with 2 years history of progressive upper extremity weakness. The right worse than left, there is no pain, denies any dysphagia, denies any dysarthria. On examination, he has weakness, atrophy, and fasciculation. There is weakness, atrophy, fasciculation in the hand muscle, right in the more than the left. The lower extremity is not affected, sensory normal. There is a past history of seasonal allergy. In the follow-up 3 years later, the hand weakness is improved or stable. Okay, no weakness developed in the other area. Whenever this typical scenario, Asian, atopic history, there is some cord involvement, stopped. Okay, this is typical Hirayama disease, or we can also mention it as monomelic amyotrophy. Okay, so this is typical Hirayama disease or monomelic amyotrophy, the condition involving the Asian origin. That is progressive wasting involving one and more hands and forearm. The examination shows atrophy and fasciculation with no sensory deficit. This patient having a high incidence of atopic disorder. Okay, so this is very important. This is still the pathophysiology is unknown. Sometimes they some manifestation they so that there will be chronic compression spinal of the cervical cord. There's some dynamic changes of the cord. The MRI of cervical cord inflection demonstrate cord thinning could be possibility. So as there is some cord thinning, so there could be role of the cervical collar. Okay. This is not amyotrophic lateral sclerosis because this is progressive. It will not stop. Okay, and the issue is that it's symmetrical, but it's most likely asymmetrical presentation is here. So this is primary lateral sclerosis. This is upper motor, but the case is not consistent with upper motor. Spinal muscular atrophy. There could be androhorn cell, motor neuron affecting upper and lower muscle as well. Not typical. So I guess it is a monomelic amyotrophy. Hirayama disease could be the best possible answer as well. Now, a 77-year-old man having history of the hypertension, diabetes, hyperlipidemia, coronary disease, having an open repair of thoracoabdominal aneurysm. Okay, when he wake up from the surgery, he is in pain, cannot move the leg, cannot have a sensation, pain peak to the leg, is able to feel the vibration and proprioception from the toes. Okay, so cannot feel the anterior part of the spinal cord because there is some, there's a motor involvement as well, involving of the spinothalamic tract. So most likely syringomyelia could be there. There could be anterospinal artery occlusion. Okay, so the patient most likely having a cord infarct, as there is a lot of comorbidity, having the surgery, there could be a lot of blood ongoing blood loss. So could be having this infarct. Okay, so as the patient is having infarct in the territory of anterospinal artery, the artery blood occlusion, they can have one artery with two posterior spinal artery. The former supplies the anterior 2/3, the latter supplies the posterior 1/3 of the spinal cord. The patient having the weakness below the lesion with pain temperature involvement, sparing the dorsal column, they have typical of anterospinal artery occlusion. It could be possible whenever we are going to repair a abdominal aortic aneurysm repair. Okay, so sometimes the endovascular approaches having a lower rate of complication, but we should remember the issue as well. So this is not copper or B12. This is not that much rapidly. Rapid onset symptom, rapid onset. You always think of cord infarct. Okay, whether it is syphilis, whether it is watershed, whether it is abdominal repair, whether it is patient having atrial fibrillation, doesn't matter. Acute onset, cord infarct. First possibility. We need to exclude that as well. Now, the last question. The patient having intravenous drug user, 1 month history of fever and back pain. Over the past 3 days, he has developed a progressive lower extremity weakness and urinary incontinence. So there's a back pain with fever, now developing the cord compression, right? Over the span of one month. There is high temperature, there's paraplegia, sensory at T8, rectal tone decreased. So I guess there could be some association. So what is the most common possibilities here? So correct. So lumbar puncture, I guess it is not that much indicated here. It's most likely a abscess. Okay, abscess that is caused by the IV drug abuser. The staph in the skin goes to the blood, goes to the back, causing this problem. Okay, so MRI of the spine is not sensitive. It's a very sensitive. You should do it. The MRI, the neurosurgical consultation, of course, required. The commonest pathogen is the Staph aureus, broad spectrum antibiotic for a long period of time. So the most possibility is the Staph aureus is the common pathogen. Okay, so it is epidural abscess. Commonly, whenever the infection extends to the epidural space, direct extension or remote via the hematogenous spread as well. So there is a lot of risk factor like the diabetes, the IV drug abuse, or previous infection, or history of the spinal injury or surgery, renal disease. We should remember these facts as well. Patient having fever, back pain, progressive neurological syndrome attributed to cord and root compression. There is a myelopathic feature developed over time. Patient having upper motor neuron feature. There is some findings of shock, but as the time ascend, the possibility shock is less. Okay. So MRI of the spine is a standard test. In this case, spinal lumbar puncture is not usually performed. It is contraindicated in the because it can spread the infection as well. The CSF culture only 25% is positivity. So the most common organism is Staph aureus. Then it could be streptococcus, then it could be gram-negative, then it could be anaerobic as well. Particularly, we should treat the patient with broad spectrum antibiotic, particularly 4 to 6 weeks at least. Okay, but issue is that this is not importantly, we should also do a neurosurgical consultation should be there, because as there is evidence of cord compression, surgical evacuation should be done. Because epidural spinal abscess is a true neurosurgical emergency. It's a neurosurgical emergency, right? We should treat the patient by checking the neurosurgery and neuromedicine. So that's it from this session. Yes, right. So thank you so much for your kind hearing. Thank you so much.